السلام عليكم. Hello, good morning, sir. نعم. Hello. Hello.
something. Why will you stay in New York? When you never even enter your own house, you don't be your never you buy car, you just say something. Then you know why they think that big?
They are not able to make me to get annoyed. I was here. Calls. And they can even when pay man around here. How much you got bagasa? How much and I got
in kika shiga sai ki minimize ki cike
then I went to vitamin C
in the city of Fiji, to be able to encourage that Syrian democratic forces for the battle. We cannot negotiate with Iraq. In the second of Dara, the birth of an anti-government protest that we thought.
Hello, good morning. Good morning, everyone. Hello.
Good morning, sir.
Yes. Good morning. Yes. So you can hear me. You are all welcome to this week workshop. Our facilitator has joined us already. We will soon share the screen and start.
Wait, how am I supposed to do the story? Don't give me any questions.
All language, not even Hausa. I mean, this is because they are subtitles, they are perfect. One Hausa woman is
2 and 2.
Doing any bad.
somebody's son is calling him daddy at the background.
Táwọn Haúsá ló pọ̀ ní ìpínlẹ̀ tó ń sọ.
Please, let's try to mute ourselves, please.
What's the plan and watch?
Daddy Michael, kí ni problem ọmọdé? Wọ́n ní lọ ṣe shopping elsewhere. Which one?
Daddy Michael, kí ni problem?
No, which money? Ṣé owó tó ṣe fún mi padà ló fẹ́ gbà padà sí? Is it the money that you gave me?
Hi, please, your mic is not muted.
Mute your mic.
Hey, wait now. Torí pépè orí ẹ̀ wá láti ṣiṣẹ́ mọ́.
Nobody speaking Yoruba with their husband, Daddy Michael.
It's because the interview has not started yet. Once it started, nobody will be muted.
It's good. I like it. Did she put lip in? Only ginger. She grinded the ginger. This is not only this. She put fresh one in. The tea cannot be strong like this. So. Fresh one did this one. You said? Okay. This is a strong food.
Mute everybody.
Thank you. You said the constipation. And see me, I don't forget not to be cucumber for you. This is the vlog here. You know the video.
I suggest the host should mute everybody.
I said they should mute everybody. Unmute us, please. This one is fresh ginger. It's not tea, but it's good. I'm sure she grinded.
Alhasan, in tashi lafiya. Lafiya, alhamdulillah. Za a fita neman kuɗi.
Somebody said now put a name on Kuji that they have gone out to look for money. They have not muted the background. Everybody is saying whatever they are saying here. Maybe my own message they are hearing.
Hello, good morning.
Good morning, sir.
Everyone. Please, we are expected
Thank you
to
very
meet
much.
ourselves. Everyone should meet
Please, sir,
himself,
unmute
please.
us.
The host is having issue with his network. That's why he couldn't meet. Please mute yourself. Amina, how well? Ayodele, Chooks. Please mute yourself. Fatima, mute yourself, please. Abubakar Show, please mute yourself.
For reasons that are the peculiarities of what we are doing. I think the best for it is a such. Such before. And so this is very, very good.
I don't understand. You never see balloon. You don't see balloon.
Sagari. Yani. Akwai.
Hello.
Ihe a niile bụ ihe eji ele ya ego. Ka anyị mee ya ebe m na-emenụbeghị ya.
Hello, good morning, everyone. Is applicable to all fields of level, and healthcare sector is not isolated from the need in order to ensure an effectiveness of healthcare delivery. Excellent. We can move to Hello, I'm waiting for the slide to move on.
Okay, Dr. Umar, we can't hear you before, but I don't know if you are set now. Before we are not audible.
you can zoom the slides a bit. You can zoom it. Yeah. So understanding the nature of management, usually management has functions such as planning, organizing, directing, and controlling. Please zoom the slides a bit. The writings are a bit shiny. Yeah. So management, as you can see, is a dynamic process which involves planning, organizing, staffing, directing, and controlling of resources to achieve organizational efficiency and effectiveness in healthcare organization in order to provide a quality service delivery, which is the ultimate aim of any healthcare institution. Management operates within an environment, and this environment is dynamic because there's a lot of factors in the environment which vary. That's the reason why management must always be applied in order to make sure that you have a control over your environment. Because usually the environment consists of the internal environment and of course the external environment. So as a person, manager, you can only control the internal factors within your organization, which are within your reach, within your own capability and ability. But you cannot you cannot control the external environmental factors, which might be political, economic, social factors that may come onto your organization. The only thing you need to do is to apply these management principles theories in order to ensure that you have managed positively any change that may come from the external environmental factors. And this environment is changing, is dynamic. Next. Management is a multidisciplinary, concept. It's a multidisciplinary discipline. It's a combination of so many disciplines that come out to make management. We have business professionals, we have healthcare professionals, we have legal and ethical experts, all coming into healthcare environment as managers, to form a combination of force in order to manage organization very well. Next. So healthcare organization is unique. Yes, it's unique in the sense that when you apply management concepts, you should be aware that you are not applying these management concept theories and principles in a factory, for instance, manufacturing plastics or manufacturing biscuits. No, healthcare organization is unique because it deals with human beings, it deals with patients. So it's patient-centric approach. It prioritizes patients in order to ensure efficiency and to ensure safety of these patients. And management application in healthcare is like application of management is a complex environment because you have a lot of expectations as far as the stakeholders, the patient relations, all are expecting efficiency and effectiveness. It has a diverse stakeholders. We have old patients, we have new teenage patients, we have pediatric patients, we have management, we have patient relations, so a lot of people are having interest in the healthcare. That's what makes it a complex. Next. We start from the classical theory. The classical is the principles which were adopted in order to improve efficiency in organizations. We also have which has to do with the consideration of the human relationships among the workforce, because we observe that it's not only providing the tools, the equipment that makes of a good management. It also has to do with the management of the relationships of the employee, because human being has a behavior that is unpredictable. The behavior of the human being is complex. That's why even management has to do with also psychology. A lot of psychology theories are applied in the field of management in order to understand the nature of human mind, human behavior, in order to predict the behavior, in order to come up with certain actions that will be positive to the organization and, of course, to the employee. We also have the contemporary theories of management, such as the system theory, which consider management organization as a system, where you the input, the process, and the output. You also have organizations as a closed system or an open system. Organizations that are open system are organizations that allow input from the environment, and organizations that are closed system are those that are closed and does not allow any input from the environment in order to manage. So these are the way you can also temporary era. Next. So management guides healthcare delivery in terms of allocating resources so as to get an expected positive outcome, because management avoids arbitrariness and lack of objectivity in decision making. So management at times is viewed as a science because it's standardized, it has procedures, it has theories, of course, that are applicable in order to have a desired outcome. So planning is the first function of management. We plan because we cannot foresee future. So planning has to do with forecasting, with predicting, in order to make things come to your own advantage. So in healthcare organization, planning is necessary in order to achieve the desired outcome in terms of budgeting, medical supplies, employment. All these needs planning. As one management writer, Peter Drucker, used to say, he who failed to plan, planned to fail. So planning is inevitable. You either plan to succeed or you plan to fail. Then the next functions of management is organizing. Organizing involves creating a structure, assigning responsibilities, and coordinating activities in healthcare. And this includes assigning roles of staff and creating efficient workflows. So if you look at this explanation of organizing, basically you can see that it's talking about organizational structure. That is, you have to get the organizational structure, which assign roles, responsibilities, accountability, formal channel of communication, and workflow within the organization, within the department, or within the units. So this organizational structure is the same as it is called organizational chart. It is also the same with organogram. So it has assigned responsibilities, coordinate activities in healthcare. This includes establishing departments, assigning roles to staff, and creating efficient workflows. You should know whom to report to, who is reporting to you, who you should communicate to, etc. Then the next function of management is staffing. And staffing means recruitment. Staffing involves recruiting or hiring, training, and managing personnel to ensure optimal performance in healthcare. This includes selecting qualified healthcare professionals and providing training programs and to foster a positive workflow. This means right from the advertisement, even before the advertisement, the first activity in staffing is vacancy. You have to identify the vacancy, the vacant positions. This is also an aspect of the manpower planning, which you do your analysis, you did your analysis, and you now identify vacant positions. And vacant positions can be as a result of someone resigning, someone retiring, someone has died, etc. So all these, or someone has been terminated or dismissed in the job, on the job, then a vacancy exists. Then you have to now advertise. When you advertise, then you shortlist, then you conduct an interview, then you select, then you place. When you place, you make sure that you place the person at the right position. Let a square egg be in the square hole, in the right place. Let there be fitting. A personnel should be fitting. That's why there's a need for job specification. It's not just the job description which describes the job that is to be performed and the salary and the work. But there should be specificity for the job. Who is better to play that role? The kind of characteristics required for the person to do the job so as to fit properly on the job. And then the next function of management is directing. Directing, leading, motivating, and guiding employees to achieve organizational goals in healthcare. To provide tasks, to conduct tasks, providing feedback and motivating staff to provide high quality performance. So directing is not just telling someone what to do. It's also about showing the person how to do it. And not just telling him or showing him how to do it. You have to provide the needed motivation. You have to provide the equipment to do the job. You have to also provide supportive supervision where he doesn't know how to do some parts of the work. You have to support him and for him to do it. That's what directing is all about in management. It's not like you stand up like a soldier and you direct someone, you must do this, you must do that. No, that's not directing in management. You show how to do it, you provide the means of doing it, you support where the person is weak in doing it. Because human beings are not the same. They don't have the same capability. So some can perform better than other ones, some can be more efficient than other ones. So the ones that are weak, you need to support them. And that supporting means you show them how to do it, you guide them. Even when they need further training, you provide opportunity for them to go for the training so as to meet up in order to improve their performance. The next functions of management is controlling. Controlling involves monitoring performance, evaluating results, and taking corrective in healthcare. This includes tracking key metrics, assessment, patient satisfaction, etc. Yeah, controlling is about setting standards. When you set a standard, then you measure the performance based on the set standards. If the employees or the staff, the healthcare personnel, perform up to the standard you've set, that means you have a total control. But if the performance is less than the standard, then there is no total control. That means you have to improve. You have to show a correction. You have to correct what is not being done. This can be done through setting rules and regulations in the department, in the unit, in the clinics, that this must be done. Closing time, social time, punctuality is a key. So all these are standards. Then you measure the performance. If it's up to the standard, then that's good. You are achieving a total control. But if it's less than the standard, then the control is weak. Then you have to correct it. Next. Usually, principles of management are key in ensuring efficiency and effectiveness in healthcare organizational performance. Then we pick the popular principles of management by Fayol, who came up with 14 principles of management. These are basically principles that
kawai
when
da
applied.
everybody amma the NSP da za ka ga in ka ga dama sai ka tafi ba za ka yi joinin ba a kasan.
In terms of performance in the healthcare organizations. For instance, we have a division of work. There should be a division of work. In your department, in your unit, in the clinic, there should be division of work. Who should do this work? And who should do the other work? And who should do the other work? So that when combined together, you have a whole work that has been done with efficiency, with speed, with accuracy, and with minimum stress. So this has been a very popular principles of management that has been that has originated from economics. Concept of specialization. People will become specialized. Of course, performance will be increased whenever jobs are divided based on division of labor. Then the next one is a principle of authority and responsibility. There must be responsibility, or there must be someone that is responsible for a particular job. And there must be someone that has an authority over the job to be done. This will show a track of who should be held responsible and accountable for a job not done well, or who should authorize a work to be done well. This is a very important principle that can be applied in healthcare institutions, clinics, departments, organizations, and even in your home. Right from the division of work and of course the authority and responsibility. Then we have the principles of discipline. Discipline simply means respect to rules and regulations. When you hear they say someone is very disciplined, that means you respect rules and regulations. Discipline him may mean in let him conform to rules and regulations. So there should be collective respect and compliance with the rules and regulations of the organization. And if that is done, it's going to improve the work efficiency and effectiveness, and things will always be done in a nice way, not negative way. So in productivity in terms of service will increase. Next. Then the principle of unity of command. This principle simply means there should be one person that is commanding. You should not have people giving commands. That's the reason why in the structure we do before, there is layer of authority, and there is a flow of communication, and there is area of responsibility. So someone should be responsible to this. Is not, you cannot as a boss be talking to someone that is at the lower level. You should have a supervisor, and that supervisor should have someone upper, and also there should be unity. You know, like you can confuse an employee if several people are giving him, because commands may not come uniquely. Someone will say, do this, another person will say, do the other thing. So there will be confusion. And even conflict of roles may occur. And of course, it will become a source of demotivation to the staff and even frustration. And if this thing continue repeatedly, he may even start to have a sort of a kind of depression on the job, because he's not happy with the job. He's not satisfied with the job. Unity of direction. Unity of direction means the organization, the department, the clinic should have a common direction. Now we call it a vision statement, which is single to which you want to achieve. And of course, you should have a mission. The vision should be broken down into missions, which it will serve as a strategy towards achievement of the mission. So this unity of direction is what everybody will focus on. That's what the top management will focus on. That's what the middle management will focus on. That's what the operational level staff will focus on. All having a unique organizational culture, irrespective of geographical distribution of the staff in the organization, but they are bonded by a common vision, common mission, and common direction towards achievement of the goals of the organization. Then we have unity, we have subordination of the individual interest. What it means here is a complete loyalty to the organization you are working, irrespective whether it's a private organization, private healthcare organization, is a government organization, is a primary healthcare, is a secondary healthcare, or is a tertiary healthcare, or it's an NGO. You should have the interest of the organization at heart, and you should support your own interests to the interest of the organization. If the organization says reporting time is 8 o'clock, and you don't like waking up
teach yourself of Africa's weather because
you know your
in hot weather.
Up with the target of the organization because you've already signed a contract with it. So with the organization, so you need to come on time. You need to subordinate your interest to the interest of the organization. Your interest should come second. So these principles, if that is done, definitely the organization is going to perform wonders. You can imagine an organization of 50 staff, 100 staff, 1,000 staff, and everybody wants to put his own interest first, not the interest of the organization. You can just imagine how the organization will become disorganized, and it may not be able to achieve its own target, its own vision, its own mission, its own objectives, and of course goals. So you have to subordinate your own interest to the interest of the organization. Another wisdom in that is that it's only when the organization survives, you know, that it can be able to pay your remuneration. So therefore, you have to support the vision of the organization so that it survives. And when you survive, you become stable on the job, and of course, get promotion, staff development, career development, etc. Then the next principle is the principle of remuneration. There should be fair in remuneration. The staff should be paid based on the performance which is doing. Don't underpay a staff. Because if you underpay a staff and he's doing his best, definitely demotivation will come. Frustration will come out of that job. That's the reason why at times when you want to also put a price for your own products and services, be it government, private, clinics, hospitals, healthcare institutions, you need to do what is called industrial average. Look at the environment, find out what the other people are paying, what this state is paying, or this company is paying, and you add, for instance, 3 of that. Then you take the average of the payment. Then you find out that, oh, then I must not pay below the industrial average because this one pays collectively, I've added, then I'm divided, and this is what I got as per the remuneration template. Then maybe I should even increase, or I should not go below that, so that at least the staff will know that his own organization is not underpaying him. They are not exploiting him, because there is a relationship between motivation, morale, and productivity. It's only when someone is well motivated that he will be in a good state of morale, which is enthusiasm, confidence, feelings, happiness, satisfaction, and that will also lead in turn to productivity. And this productivity may be now translated into profitability or good work indicators or success story about your own organization. Then after remuneration, we are talking about centralization. That means there should be balance between the top-down decision-making and also delegation. Then someone should be centrally responsible for all decisions, so that a decision should not come as in unity of command. There should one. So centralization, that means there should be central who should be able to delegate to, you know, merge individuals from both departments and units and sections together and give a final authority, so that there should not be a multifaceted source of authority, command, and direction. Next. Then the principles of scalar chain. This principle of scalar chain is also called the principle of span of control. You know, we mentioned previously that human beings has a very complex behavior. It has an unpredictable behavior, and also there is a need for managing relationship between the staff. So when you dominate yourself with so many staff to supervise, definitely you are bound to be inefficient. There's going to be stress. In fact, that is the concept even called a fire brigade approach to management, because actually you see so many people coming at the same time, people falling at the same time, and this is what is called crisis management. The manager or the healthcare manager or the supervisor or the HOD may not be able to concentrate well on his job. He's thinking of meeting. He's thinking of signing something for a drugs or equipment to be released. You're also signing forms and whatever. Also, people are reporting because they fought. So when all these things happen, it leads to crisis management. That's what it's called, crisis management. Then there is need to limit the number of people that should report individual damage. Principles highlighted that at least not more than 4 people should be able to report to the superior officer at the same time. Otherwise, there should be layer of supervision, layer of reporting. Move to this person first. If you can't solve, then that will reduce, concentration of people on individuals. These people should not have more than 4 people being supervised by that is principle of scalar chain or span of control. Then principle of order. Why that when you are managing a unit, a section, a department, a clinic, or a hospital, or any organization, then there should be order. And order means when you are applying it to human beings, then it means there should be a place for every staff, and every staff should be at his own place. You should have office for every staff so that people would not be roaming around doing nothing and earning salary. Then there should be a place for every staff to sit on. Let there be a place for every staff, and let there be a staff for let there be a place for every staff, and let there be a place for every staff to work and engage in the organizational activities, so that he will not be wasted. But when you are applying the principle of order to materials, like the stocks, the equipment, the drugs and consumables, there should be a place for everything, and everything should be in its own place. Even in your office, let there be a place for everything that is in the office, then let everything be in its own place. For instance, if you overload your office with so many things, you find out that some does not even have a place to be there. So let there be, if it's books, let them be on the shelves. If it's a refrigerator, let it be perfectly fixed where it's supposed to be. So the office should be orderly, not disorderly. And people should be orderly, not disorderly. That's what the principle of order is all about. Then the next principle is the principle of equity. Equity is talking about treatment of treatment of equality, treatment based on equality, treatment based on fairness, treatment based on justice. Equity means you should not show any paternalism. What is paternalism? You introduce a father figure into the management of your work. Among your staff, you pick someone as your daughter, someone among them your son, my daughter, my son, daddy in the workplace. What about the other ones? So when you start calling someone daddy, that means that he may have on you. He may not even give you a schedule that he feels maybe is difficult. He may give it to another person. So that's what is called paternalism. Then we should not also show favoritism. Favoritism means you favor someone against another person. No, treat people equally without partiality. And there should not be nepotism. Incidentally, your nephew is working in your department. So you can come to work today, you cannot come tomorrow, because he's going to your wife's house to help and do something else like that. So that is nepotism, a kind of discrimination based on blood relationship, or ethnicity because of tribe, or tribalism, etc. So all this one negates equity, negates fairness, negates justice, because equity is not even the same thing with equality. When you say equality, that means you are making everybody equal, irrespective of whether that person is strong enough or not enough. So it's not about equality, because some people are naturally weak. They are not as fast as the other people. Even some are stronger than the other people in terms of job performance. So when you say you rate them equally, then they are not. But equity is saying that you are showing fairness, you are showing considerations, you are looking onto the weakness of the other people in order for them to also exhibit their ability to function efficiently like other people. This is what equity is all about. Then we also have the principle of stability of tenure. Stability of tenure means should be stable. So reduce turnover and improve organizational efficiency. When you see people leaving the organization, living consistently, that means the stability of tenure is affected. Because right from time, even the cost of the recruitment is heavy. Organizations spend money to recruit, to advert, to invite people, to type, to even use a lot of staff to come for that interview, leaving their job, which is may even affect the organization somehow because of that recruitment exercise. Then at the end of the day, people are living in numbers. So this one needs to be avoided in order to ensure that people stay on the job and perform. And when leaving, there is even ought to be what is called exit interview. Staff is going, you need to give him time to ask him why is he leaving. If he tells you that it's because maybe there's no motivation, there's no this, social things have not been paid to us, this and that, then you have to now see if you can support to say that you can provide all those things that were missing so that he can stay back. It's better. It's more cheaper for you to maintain him than to go out and recruit another new staff. And if he insists on going, all these of why staff are leaving, then you have to look at the aggregate reasons why they leave based on the dissatisfaction. Then you have to make sure that you solve that problem in order to avoid the future staff from leaving the organization. That's what stability of tenure is all about. It's very useful in healthcare organizations. You can see how people now are running away from the country, going to London, America, Dubai, Saudi, etc. So we need to track out why the people are leaving and try to provide that missing things, the gap, and correct it. Then we have the principle of now, next, the principle, next. Principle of initiative. Initiative means you have to allow people to be innovative. You have to allow people to come up with their own initiatives, innovation that will motivate them and make them happy on the job. And that will also bring a kind of innovation as a whole in the organization to make the organization unique, because you are having a vibrant people that can think, can innovate. So you have to give room for staff to innovate, to initiate. Don't be the boss kind of leader where anything you say goes. You don't allow people to talk or to bring their own innovation. Or of course, God given talent. So allow him to exhibit that talent, support him so that the organization will have a vibrant staff full of innovation with initiative, and that will bring improvement in outcomes, in productivity of services, etc. Then the next principle is principle of esprit de corps. This is a French word. It means principle of team spirit, which enhances unity and morale. It brings about enthusiasm. It brings about loyalty to each other and confidence feeling among the staff. When the staff are in a good morale, they respect themselves. They are all bonded by a common mission and vision of the organization, and they all move towards the success or objective and goals of the organization. So that's what esprit de corps is all about. Next. Okay. Operational efficiency, financial sustainability, human resource management, and technology integration. You know, we are now in the era of technology. So all these are things that need to be applied in healthcare organizations in order to have general improvement in outcomes, in service delivery, and of course, in achievement of the objectives of the healthcare organization. Operational patient-centric, you have to consider you are dealing with patients. You have to improve on operational efficiency. You have to ensure there's a financial sustainability because nothing works without money. You have to manage your staff very well and, of course, recruit the best and manage them and ensure that they stay in the organization. Then you have to integrate technology because technology is the in thing now. Technology is good. Without technology, people even run away from the kind of clients or patients or customers who run away from the organization, and that will lead to revenue loss. You not get the desired money you need to get because people are not coming. The clients are not coming. After all, business and whether it is business oriented or service oriented organization, it's about people. It's about patients coming, you know, to patronize your business. So technology now is one of the basis of people coming to organizations. Some organizations are technologically rich, while some organizations are technologically poor. You know, technologically rich organizations, you find out that they provide services that are friendly to patients and improves their satisfaction, and it works with speed and accuracy and reliability, and it reduces stress on the patient or client. So integration of technology is very, very important. Next. Then let's now understand the styles of management, which is basic that we have democratic leader, autocratic leader, and of course laissez-faire leader. Autocratic leader is like a leader, a one-man leader. You know, he's someone that thinks he's the only boss and he doesn't receive any input from his staff, no participation, no advice, no anything. He centralized decision making and he has strict control. Then we also have democratic. Democratic, you know, he allows participation, teamwork, collaboration. You know, he receives advice and input from his own subordinates. So this what makes the staff to have a morale, you know, confidence feeling, enthusiasm, happiness, and satisfaction on the job, so that they contribute their best towards the attainment of the organizational goal and objectives, especially in healthcare organization. While the laissez-faire it now has minimal intervention. It's like I don't care attitude, whether you do or you don't do. It's all right for me as a leader. Even when you see you not doing the job, he join you to watch the football you are watching instead for him to improve on the job. So that's a laissez-faire. He lack direction and he's not even the best. But the issue is, some people say all these kind of leadership styles, it depends on the situation you find yourself. There are some situations where autocratic leadership is the best. Then there are situations where laissez-faire leadership is the best. Before we had a military regime and people were clamoring for democracy. And now some people are also clamoring for a military regime. Military regime is more of autocratic and dictatorship. No national assembly, no state assembly, it's the decree, not act, no constitution. Once military comes, constitution is suspended, no longer operational. is only the decree, and the decree is just 10 people or so. Even the head of state may just say, let there be a decree like this, and they will announce it the next day, and it becomes a basis for compliance by all citizens of the country. So this is like autocratic, then democratic. So it all depends on the situation to apply the leadership style. We also have a transformational leader who inspires innovation and motivates employees towards a vision, requires strong communication. And these transformational leaders, they are the ones you see them coming, modernizing, learning, and so leaders. Then we have also the next one is a transactional leader. A transactional leader is different from transformational leader. Transactional leader, he calls across his subordinates and also communicates with them in order to make sure that he achieves his aim and objectives. Next slide. So the managerial grade is a kind of grid, is a kind of diagram designed by a management expert called Blake and Morton. Blake, B-L-A-K-E, and Morton. Maybe later on someone will Google and find out what he actually draw in that place. But this is just a pyramid, so that in that different types of managers. As a team management, which we allocate 9 to 9. That is a team management, and they have high concern for people and it's the same of high productivity, high commitment work. So they gave them a ratio 9 to 9. They have 9, which is the high concern for people, and another 9 higher concern for job, for doing work. This, he called them team management. Then you also have management. This, he gave them 5 for high concern for people, half concern for his other 5 ratio, 5 to 5. The other 5 is high concern for production or commitment or work. So that means they are half. We call them middle of the road management. He's neither too harsh, he's never too simple. He's midway. Then we find a task manager who he's only concerned for task. Just do work. I don't care whether you are sick, whether you've not eaten, whether you don't have salary or you have salary, whether you have the equipment or you don't have the equipment, you must do what I want you to do. That is task. He has only high concern for production and low concern for people. This is the opposite of the team manager, who is 9-9, high concern for people and high concern for the production. And he's also known as the middle on the road. Who is the middle? He has half concern for people and half concern for people for production. This one, the tax has only 9 ratio to 1. That means ratio 9 to 1. That means he has high concern for work, and he has least concern for people. He doesn't care about people. So this is another kind of manager or leader. Then we have the country club manager, who is reminiscence of the laissez-faire. He has high concern for people, but less concern for work. You have high concern for people, less concern. He's the social type. When he comes and meet them chatting, playing cards, or in the work situation, he just join them. And he doesn't care whether the work is done. and that's why it's called country club manager. This is the explanation of it, and it's also called. Then the next one is impoverished manager. This one, he has only high concern for work and least concern for people. He's impoverished. He's creating a poverty among the staff because he's only concerned for the job. In fact, in management, he's also called a name like a machine man. He's like a machine man. You know, only people should use machine or machine that doesn't rest. That's how he consider people as machine. They just work, no rest, no concern for them. So this is a kind of framework that was brought up by Black and Morton, and under the guise of managerial grid, you know, to evaluate the kind of leadership characteristics or inherent in. Next. You know, we talked about transactional leader, transformational leader who build, you know, a lot of structures, you know, vision, he has a vision, etc. Then the transactional leader has a clear expectations too, performance-based rewards, employees are rewarded, meeting performance, etc. Then he also has consequences of non-performance. This is the aspect of the transactional leader. Next. In organizations, conflicts are inevitable. Conflicts are inevitable. I know all of you that are working, of course, you used to find one conflict or the other in an organization. At times you laugh even though it's conflict, or you argue while laughing. At times you even keep malice. At times the conflict may even be you on your own. You are not even happy with yourself. You are not. When agreement, or role ambiguity, or mood, or even someone has spoiled your mind right at home and you carry that emotions to the office, then you find yourself in a state of conflict. Okay? Then we also have a group conflict, which arises between teams or departments. Then there's a conflict at that level. Then we also have organizational, which means one organization and and another, and also organizational in terms of conflicts based on the policies of the organization or organizational goals. Then there's a need for healthy conflicts. Healthy conflicts arises when all people are having disagreement or arguments based on achievement of the organizational goals and objectives, not based on personal or negative reasons, but everybody is striving, bringing new ideas and arguments and debates in order to promote and advance that particular healthcare organization. That's what is called a healthy conflict. So in essence, you should try to minimize unhealthy conflicts and you promote healthy conflicts. For instance, let's take an example of when you are maybe defending your dissertation or thesis or what have you. You find out that among the scholars there might be some certain arguments on the methodology or on your analysis or on your statement of the problem. They will be arguing among themselves. So this is not a negative conflict. It's a conflict that is healthy because all of them want to have a better outcome as far as that thesis or academic work is concerned. So that is a simple example of organization. Or at a meeting, everybody should be bringing his own viewpoints from different departments, advancing it to the management from your own perspectives and opinions and professional basis. so as to promote the organization as a whole. So this is a healthy conflict. So generally, unhealthy conflicts should be minimized and healthy conflicts should be improved. Next. So what are these sources of conflicts? Competition and rivalry is a source of conflict. Struggle for power, struggle for resources, struggle for recognition, etc. So all this is a source of conflict, and of course, differing values and beliefs, varied perceptions on patient care and organizational priorities may be a source of conflict. That's the reason why you have to improve communication. You have to improve communication. You have to improve dialogue. You have to even minimize paper writing and encourage face-to-face communication so as to, identify or bring a better explanation. Then you also have a miscommunication, as I've said, which leads to misunderstandings and disputes. With better communication, people will understand clearly what is at stake, and of course, minimize the need for conflict. At times, even conflicts in organization in terms of the industrial disharmony is as a result of lack of communication. But when there is a dialogue through collective bargaining to come up with collective agreement, you find out that that dispute has been resolved, in order to avoid, for instance, industrial strike. Then we also have stress and stress, high pressure contributes. It leads to frustration, leads to emotional even break in the office because of stress, burnout, and so many reasons. So someone is tired. Of course, he may be prone to fighting and anger or talking indifferently, which may lead to a negative consequences as far as relationship is concerned. Next. So what are the ways to resolve or to manage conflict? The strategies are negotiation, as I've said. Even if it is industrial dispute, you negotiate, then you find a way out. It might be even a win-win situation where this one will win, this one will win. Try to avoid win and lose situation when it comes to negotiation. Don't say I must win and the other person must lose. You have to get a shifting ground. That's the reason why, if you observe, when there's an industrial dispute declared by maybe the unions in the health sector or what have you, so whenever government, give a little support or elite it out of the grievances of the unions, you find out the union will have no other alternative than to withdraw and maybe give another date for other things to be achieved, because there must be compromise. You must not have a win. You must not have win alone situation. No, you also have to understand the other person also have his own concern, and you too have your own concern, and you cannot get all what you want, and that person may not get all what he wants. Therefore, there must be a compromise in order to achieve a balance in terms of collective agreement, which should be binding on everyone. Then there's also mediation. Neutral party facilitates resolution, but there's a skill in doing that. You advise to put the two people together at first sitting to say you are going to resolve them. No, call them individually. First, call the first person, ask him what went wrong, and strike a deal with him that you are going to intervene. And please, once you talk to the other person, he should also agree on that. You promise the person that you're going to put all his concern to the other party, so that this thing should not repeat itself. Then when he goes, you call the other person to, you discuss with him. Then later on, you call them together because you've already agreed with them. You know, if you look at this conflict, it's like two cycles. When they are joined together, the two circles, you know, it produces what? Areas of intersection. Is it matrix in mathematics? So that center area of intersection, you can even shade it, that's the area of conflict because the two circles are clashing. So therefore, by talking to them individually, you are separating the two circles together. And when the two circles are separated together, then you see temporarily there is no conflict until they mix together. So when you talk to them individually, then you already allay their fears, build confidence, and also correct all the misgivings each person was having. Then you can now join them together without that shaded interception as a sign of conflict. Then they will live together harmoniously. Then the next one is collaboration, working together to find a win-win solution. You see, win-win solution. So all of them should collaborate so that together they succeed. What is she himself as a so negotiation, mediation, a neutral party facilitates resolution, and of course collaboration. As I've said, negotiation, you negotiate, then you mediate as a neutral party, which I said you should separate the conflicting parties because it's like a cycle. When you join the two cycles together as a matrix, it brings area of intersection, and that area of intersection, you can even shade it, that is the area of the conflict. But when you separate the cycles, no conflict. So you talk to the person individually, you correct the misgivings, and of course, build confidence, and assured of solving the problem with the other person. Then you call the other person too. You solve it, Then collaboration, you collaborate, to form a win-win situation, which I consider it as what happens in the history of our nation. There was no victor and there was no vanquish. Everybody was a winner. So when you do that, because actually some people don't want to lose in a situation of conflict, because when they lose, they carry like shame or inferiority complex or feeling of low esteem. Therefore, you have to create a situation of win-win situation. In fact, in a very heated conflict situation, you will find out that someone may even want to do a tactical withdrawal from the conflict just to save face so that he will not carry the shame. He will just look for a little exit, a little excuse, that will make him move out of the conflict without losing his own self-esteem, charisma, or a kind of ego. So you make what is called strategic withdrawal. You just look for an opportunity to run away from the conflict without losing your own values. Next. Hello?
Can hear you, sir.
Okay, all right. But the slides are not...
Okay, moving, right?
I can see the slide now. So additional conflict management approaches: avoidance, delay confrontation until the right time, avoidance. Don't hesitate in everything to confront a person, or to engage a person. Minimize confrontation. Then accommodation, prioritizing relationship by giving in to others' demands. What it means that some people just like their own things to be done at all times. Whatsoever they say, that's what must be done. So no, you have to also consider others' demands. You have to give in to others what they want to, to avoid conflict. Is what is expected of every conflict. There should be a compromise, irrespective of your own wish, because you cannot always have 100%, expectation in your own demands or reasons why you were in a conflict. So you have to have a compromise. Yes, spirit of give and take. There should be a shifting grounds on a conflict. Don't be adamant. Don't be saying, no, your own team must be done. No, even in your personal relationship at home and in office, as friends, as one of you have to get a compromise. You have to get a shifting ground. You should not expect everything you have in mind must be done. No, you have to also consider the emotion, the feelings, the expectations of others, and have a compromise. That also happens in industrial relations. There must be a compromise between maybe the government or the management of an organization or clinic with the staff. There should be a compromise, to have a even level ground, which would be a win-win situation for all, which everyone will be happy. So that is what compromise is all about. Next. Importance of communication in healthcare. Yes, we active listening. You have to always listen attentively. Because without listening, you cannot communicate back, and that's the reason why at times instruction is being given even before the instruction is finalized. The other person has already started talking. No, you have to listen. If possible, take notes. Good listening is part of good communication. And at times, lack of listening is what brings about bad feedback from the person. And that also creates a problem in terms of whether the next person may also get angry, or maybe the job will not be done as expected because you have not earlier on listened attentively. So you have to listen. If someone is talking, allow him to finish. Be patient. Be patient, except when he expects a feedback from you, then you give the feedback. And when you're also talking to him, he should also listen. So that is a skill in communication, of course. Then clear language. Make your language very clear. Very, very clear and straightforward, using a precise and unambiguous language, which will show explicitly what you intend to communicate, and for the other person to understand you better, and also to give you a feedback. Because any communication without a feedback is not a communication. Yes, communication is two ways. Someone should communicate, then the other person should communicate back. So one-way communication is not the best communication. That's the reason why face-to-face communication is much more important and valuable than maybe you write a paper. You can see even some medium of communications that was before used as a one-way is now improvising to make sure that there's a feedback when they do it, like a radio program. Radio is a one-way communication. But now they introduce a telephone. As they are doing the program, you can phone in, because they know that communication with feedback is not actually an communication. Then use precise and unambiguous language. Next. Feedback, as I've been mentioned, is an aspect of communication. Then healthcare building trust is crucial for improving patient care, reducing medical errors, and embracing the overall quality of healthcare services. It fosters a culture of accountability and transparency, and a continuous improvement within healthcare organization. That is, I'm trying to talk about the quality assurance in healthcare, because it's about measurement of the performance that is going on in the hospital. And you have to also do that through a lot of methods to ensure that the standards are being complied with and patients are getting the right services they are supposed to get, so as to improve their safety. And of course, it's an opportunity for also a professional to review their own service delivery in order to find out that whether they are doing the right thing or the wrong thing, and also to correct areas where there are lapses for general improvement of patient care. Units, hospitals, clinics, etc., whether it's a private practice or, of course, it's a government practice, whether it's a non-governmental organization, whether it's a state level, a federal level, or primary healthcare level. So quality assurance is a systematic approach to meet established standards. That means before you ensure quality assurance, you must have a standard. A clinic, hospital must have a standard in each department. What is the standard of care? Some call it standard operation procedure. Some call it standard care. Always be complied with. Next. So the quality assurance in healthcare brings about audits. Must bring about the concept of it's applicable to all specialties in healthcare. Professionals must audit their services, must audit their work in order to identify lapses. But the general concept is called medical audits. Then this medical audit can be broken into physiotherapy audits, into radiology audits, medical laboratory audits, radiology audits, and even clinical audits, maybe to audit the operations of the clinic. Basically, these audits are in principles and in practice in hospitals is a kind of non-punitive in nature. That's why at times I asked how ethical. You review the performance and lapses are identified, but it's non-punitive. It's just a means of correction. It's a corrective measure where professionals, review their work in order to identify the lapses and the gaps and correct, so as to improve performance of healthcare services. So that's it. It could be done in physiotherapy department. It could be done in medical in radiology department or medical laboratory department, etc. It can be in nursing. I was privileged to be a member of the nursing audit committee in a teaching hospital, where those audits were done. You review a kind of activities in a particular unit which you're checking. Then you now identify the lapses. It's a committee actually that is being formed, which include the nurses and other people of neutral backgrounds and of course of other specialities. Then you bring to the notice of the matrons, for instance, and tell them this is what you observed. and it should be improved. And the audit can therefore be served as a measure of quality assurance. Next. What is the principle of quality assurance? It should be evidence-based practices. For instance, as I've told you, we did what we call at that time a retrospective audit by reviewing a particular admissions in a particular ward based on a particular diagnosis. And we followed all the procedures. We found out what was the standard procedure for the treatment of that particular disease or sickness in that ward. And a percentage of non-performance was analyzed. So you see, this is what is called evidence-based practices. Is driving is data that has been analyzed that is driving the audit processes, and that is based on what? Responsive feedback. It's the feedback you got from an analyzed data that was objective, and you then try to correct the anomalies based on the data you've obtained. And of course, it should be patient-centered. It's about the safety, the well-being of the patient, promoting patient engagement, decision-making, and ensuring that healthcare services are tailored towards individual patient. So that is a kind of principle for the audit you are going to do. It should be a continuous improvement. It should be a source of continuous improvement, regularly reviewing the protocols and ensuring compliance and improvement. Then it should be staff competence, then training and evaluating healthcare workers based on what you've obtained from the processes and in order to improve the audit process. As a systematic analysis of the quality of patient care, which includes the use of resources, the method of diagnosis, the treatment, the resultant outcome, the patient satisfaction, and the quality of life of the patient even after discharge. All these need to be measured and to find out what was wrong in order to improve it. Next. So we are talking about ethics of management and administration in healthcare organizations. Just as we've spoken about the audit should be ethical in nature. That's the reason why, for instance, in the ethical research committees, we usually a committee. How in mortality views in the hospital, in physiotherapy audit, in radiology audit, and what have you, there is also a representative from the community. I think that will make it more ethical than to just do an internal arrangement for people to identify their mistakes and correct within themselves, because it needs to be transparent and accountable so that people should also know that. But you know, when this thing is open to people, it may lead to several medical legal issues, because at times findings of the audit may lead to medical legal issues. More so when we have a lot of lawyers looking for cases around. You know, when they realize that there are a lot of, then the hospital will be a platform for lawyers to always be coming, as if it is a court, to look for all those faults in order to use it as for litigation in the hospitals. You know, some cases can even be bought. Some lawyers can even bought a case from. So we also have patient confidentiality is, of course, ethics in healthcare, ethical requirement in healthcare organizations. Why confidentiality? Confidentiality is a product of autonomy. Confidentiality is a product of autonomy of individuals. Autonomy means I have the right for self-determination. I have the right for myself. It's given to me and by God, and therefore even which a professional has obtained is, of course, only a privilege. That's the reason why we have like what we call privileged information, privileged communication, and of course, professional confidence. What is privileged communication? This is a privilege which a patient, which a healthcare professional has, and of course, even obtain information, data, even touch him. It's all privilege. Then privileged communication leads to privilege. A healthcare professional is privileged to obtain is also confidential, because otherwise, if not because of your professional capacity, you have no right to talk to any patient. You don't have right to even touch a patient. So it's a privilege on you. And when you are doing it, then it has to be guided by ethical considerations. And more often, it also goes with consent ethics. That's why the next one is now talking about then we have professional confidence, as I mentioned. The professional confidence is a kind of confidence which a patient or client has on a professional. That was so he allows him to do. If you touch him, from him, he manipulates his hand, his leg as a physiotherapist. Then it's based on professional confidence, because the patient or the client has confidence that that person is a professional, and was everything he has done to him is based on his own profession.
1 year, 9 months.
There's not any beyond to deliver a quality care to the patient. Then, based on that, we have next one now, informed consent. Informed consent is still talking about the autonomy of the patient, autonomy granted to him as a human being. At times it's called respect for autonomy. So you have to respect this autonomy. Every law, the constitution of the country, giving him that right to study, right to movement, right to worship, etc. So all these are part of it in the constitution of our country, and of course, even the Universal Declaration of Human Rights of the United Nations, which even form partially the articles of the United Nations Universal Declaration of Human Rights form, some aspect of the constitution of some country, especially those that relate to fundamental human rights, right to life, right to freedom of movement, etc. So freedom of movement, and now dispose you to no force except with wish, because that to a kind of false imprisonment of a patient. That's why the only thing you can do maybe is to allow him to sign a discharge against medical witness, and what he do, allow him to go. He has right, he has autonomy over his body. So informed consent means consent that is from the patient. You have also declared to him all the risk, all the discomfort, the alternative procedures that he may take, and the consequences of refusal. And you have to show him element of voluntariness, that he is free to opt out for the treatment plan or the diagnostic procedure or even research participation without any kind of repercussions. And you also have to let him know that it is beneficial to him. You have to show the benefits. You have to show the risk. That's what informed consent is all about. It's respecting the human being, respecting a client, respecting a patient based on the autonomy he has, based on the respect for autonomy which the patient has. So we also have equity in resource allocation. It's also ethical consideration in healthcare. Equity is just like balancing, the ability of individuals in terms of strength, in terms of physical appearance. We have physically challenged, or maybe across inequalities in terms of wealth distribution. You find out that some are weak in healthcare. So there has to be equity in resource allocation, or maybe resource allocation to rural areas and what have you, all need to be guided by ethics. And usually, it's often better to use a kind of feedback based on evidence-based, analysis and researches and what have you, to use this as a basis for resource allocation. This will improve objectivity. It will improve equity and fairness. So distributing limited resources like ICU beds, vaccines, and special medication needs, ensuring equitable access to healthcare for all individuals, avoiding discrimination practices. That's what the resource allocation means. Concept of universal coverage of health, universal health coverage, which aims at having all population, access healthcare instead of you are well, allocation, instead of and there are strategies for in order to attain this, especially the DG3 limit, in order to reduce the mortality rate, to cure diseases like HIV, tuberculosis, and also to reduce the death of the newborn and, of course, the children. So all these need to be based on resource allocation. That's the reason why even now, digitization, people perceive it to be a means of ensuring equity in healthcare delivery system. For instance, when you apply telemedicine, which means medicine from a distance, trying to communicate or to help, people in rural areas to access healthcare through telemedicine or teleconsultation, etc., is another way of ensuring equity in healthcare. Or maybe you mobilize your professionals to move to the rural area in order to deliver healthcare services, is another way of equity. In terms of telemedicine, because telemedicine can now be able to treat large number of people in rural areas using technology from the far. And these people ordinarily couldn't have afforded a kind of healthcare based on cost and rising limitation of personnel because they are not available to go around the villages. But the technology can now help to provide equity. So these are all ethical considerations. Even though beyond that, there's also ethics of using the technology in healthcare like the telemedicine in terms of other things like maybe if it is faulty, what about the information obtained, how is it going to be managed, etc. But by far, the advantage of using the technology to solve, medical problems of people in the rural community is, of course, more advantageous than other considerations. Next. For accountability and transparency, healthcare management must justify actions, be open about policy and procedures, and ensure that actions are transparent and accountable to stakeholders, including patients, staff, etc. So accountability and transparency. You should always be accountable and transparent. You should account for every money given to you, and every money spent should be transparent. You should have the invoices, the records, and of course how it was utilized. You should ensure that there is judicious utilization of every resources provided to you for the purpose of healthcare or patients, and of course you should have a record ready, to support that it has been utilized judiciously and transparently. Of course, avoiding conflict of interest. Healthcare managers must avoid situations where personal interest could influence personal decisions, such as refusing incentives for pharmaceutical companies that might bias their choices. Well, by and large, conflict of interest is even beyond just pharmaceutical. In everything you do, you have to declare a conflict. You have to declare if there's any conflict of interest. And it's because of this conflict of interest, for instance, and let me cite the one that is more conspicuous. For instance, you are a physiotherapist, and maybe your wife or your son comes to clinic for treatment. I think based on the conflict of interest, don't allow yourself to treat the patient, your son or your wife, because probably Share with your emotion, in trying to treat him. Maybe you may not like him to feel so much. You must to review. So that next, it's even often said when you come for a meeting, you have to declare any conflict of interest you have in that meeting. You have to declare it's ethical. Maybe the person you are going to sit on his case is your friend or is your brother. So you stay aside. Maybe when his case is decided, you come back. Or maybe it's my staff and I'm the head of the department, and there is something, even in the ethical committee, when you bring a proposal and your head of the department is the head of that committee, usually he excuses himself so that he will not favor you. Somebody should take over. When your case has finished, then he may come back and continue with the rest. So try to avoid conflict of interest at all costs. Next. We've been talking about ethics, but fundamentally, the 4 basic principles of ethics, which are the most popular, are the ones profounded by Children Sharp in 1984. This formed the foundation and the pillars of school ethics in treatment, in research, in clinical trials, in drug development, etc. And of course, even in business, because all ethics were traceable to a Hippocrates, the father of medicine, when he first of all made a declaration that whatsoever make a premium non-nonsense, which is a Latin word, meaning knowingly I will not do anything that is harmful. So it's from that hypocrisy, even the business organization, business, banking, and what have you, pick their own ethics. And of course, since it's even a father of medicine, that is the foundation of medical ethics, and that's goes across all healthcare professions within the healthcare disciplines. So next, we have the principle of beneficence. We have the principle of administering. Okay. Yeah. We have the principle of beneficence. Beneficence means good, doing good. Is promoting the well-being of patients by striving to do good through kindness, compassion, and charity. Anywhere you find yourself as a hospital professional, this should be a guiding principle. Applied principle of beneficence. Show compassion, show kindness, apply a kind of charitable actions to support, show sympathy, show empathy, so show assurance, show compassion, to patients, so as clients, so that they should get the benefit of that your professionalism. So that's what beneficence is all about. And principle of beneficence is applicable not only in terms of treatment and what, even in healthcare research. That is what the Healthcare Ethics Committee look at. What is the benefit of research? What is the benefit of the research to the patient himself, community, to the hospital, etc. So there must be benefit before that is approved. Next. Then the application here is administering benefit to patients, advocating for preventive and providing emotional support, as we've mentioned. Okay, next. Then principle of non-malfeasance. Principle of non-malfeasance. Non-malfeasance means no harm. principle of no harm. In everything you will do, you must not do anything harmful to the patient. And you can see even minimizing the potential harm to patients. For instance, as physiotherapists, definitely when you are dealing with your patients, at times they feel a little bit of pains, of course, if not much, depending on the kind of procedure you conducted, to treat the patient. But to the patient, that may be a harm. But when doing it, you should do it with minimal harm. You should use your knowledge, your talent, your experience, and the technology you have to make sure that you reduce that pain, which to the patient is harm. That's why this principle of non-malfeasance, principle of no harm, at times is being called principle of least harm. Least harm. Because no matter what, at times, there must be some little discomfort or pain that a patient may have. Even in treatment, drugs do have side effects. So you should try to make sure that the drug you are going to give will have a minimal side effects to the patient. So that's what this principle is all about. You apply it, ensuring procedures are performed safely and effectively, avoiding unnecessary surgeries, and limiting the risk of medication without clear benefits. So if there is alternative to surgeries, do it. That's why in the principle of informed consent, you have to even declare the risk of the surgery, the alternative to that surgery, and the consequences of doing the surgery or not doing the surgery, the harm involved, even the cost, you need to all reveal to the patient or client before you go ahead. Next. Then the principle of autonomy we've been talking about, respecting patient choice. That is autonomy. Yes, patient is a human being. He has his own wishes. He has his own inspiration. It's God that created him. So you cannot do anything to him out of his own willingness. You have to respect his own autonomy because he has the freedom of choice. He has the freedom of self-determination. And he knows what he wants and he knows what he doesn't want. So that's the reason, based on this principle of autonomy, there's even kind of consent which is often being considered depending on who the patient or the client is. For instance, we have informed consent, and assent. When we say informed consent, this is applicable to an adult of sound mind who is capable of taking his own decision about medical decision. He is capable. He has sound mind. He's matured. That's over from 18 years, as it is in Nigeria. So definitely, if a patient or a client is less than 18 years of age, you have to be cautious. You have to be careful for him taking a decision or determining what can be done to him. Even though we have 16 years in the university, but the law said that 16 years is still a teenage, is still a minor. That's the reason why a 16-year-old cannot own a bank account, a 16-year-old cannot give a witness in court, a 16 or 17 years old cannot even vote in an election. I think 16 years cannot even own a SIM card, except if someone registered it for him. I think before it was 16, but now they changed it to 18 years old. So this is the situation. So this is informed consent 18 years old can give. But if the patient or the client is below 18 years, from 17 years downward, then what he needs to give is assent. It's usually called the assent of the minor. And this assent of the minor does not work alone. It has to work in combination with the consent of the parents or his representative or guardian. So a guardian cannot say, do the procedure for the patient or client, But the patient has the right to say, no, I don't want that procedure. So except you get the two consent of the father or guardian or parent, then the assent of the minor, then before the procedure can be done in terms of surgery or any risky procedure or blood, transfusion or whatsoever. At times the father will say, do the transfusion, and the minor, and the minor is not a minor of a child of like 2 years, 3 years, 4 years, 5 years. No, this minor is called emancipated minor. Emancipated minor, a minor that is aware of himself, he can think, he can act, but the law did not allow him to take some certain decisions for himself. So that is the kind of minor we are talking about. So it's only when he allows and the parents around, that's when his procedure can be done. Otherwise, if it's sound mind of legal age, then the procedure can go ahead. And if it's just a small baby, it's the parent now that can give the consent, and it's not informed consent, but consent of the parent. Next slide. And the application here is providing care without discrimination, prioritizing care for patients with the greatest need in resource-limiting settings, and allocating ICU beds. This is justice. Justice means is the last principles of management after the beneficence, non-maleficence, autonomy, then justice, which shows fairness, equality, and equity. And equality and equity here is it can be viewed differently. In a situation, equality is good. Treat people equally so that you don't discriminate. But in a certain situation, equality does not help alone. It has to be equity. For instance, you have a physically challenged person and you have an able person, and you say they should run at the same time. You are treating them equally. But that is not because the one that is physically having problem run faster, or may not even be able to fast, or we do it with difficulty. So for instance, in the clinic setup, you have someone that is an emergency, then you have to give him a consideration. That is equity, not equality. But if you say you are going to treat them equally, first come, first serve, then some people might be shortchanged. So therefore, you have to do, it's just like you have a short person, a medium height person, and a very tall person, and they want to assess a mango in a mango tree. The tall can just plug it without any jump. The medium person may maybe jump a bit and pick the mango, and the shortest person may kind of jump, and he may not reach the mango. Therefore, you need to bring a stool which that shortest person can climb and now become of equal height with the other people, and also pluck his own mango. So equality is good, but also equity is good, and also fairness is good. So that's what justice is all about. Ensuring fairness, equality, and equitable distribution of healthcare resources, regardless of race, gender, or socioeconomic status. So it should not be also because this person is rich, you quickly come and get the service and leave the other people that are not rich. It's not good. It's very unethical. You need to, do it ethically, even though nobody should wait beyond necessary in order to access healthcare. That one is itself an unethical something. So it's left for you to decide the best way people can now access your services with ease and without difficulty, with minimal stress. That is the reason why quality service is being used as a basis for ensuring improvement in healthcare. What is the responsiveness nature? What is the empathy nature? What is the tangibility? Tangibility in terms of all the equipment necessary in the place for patients to have a good comfort, in terms of temperature, in terms of water to drink. terms of, entertainment facilities, all these, are tangibles. Patient feel that stress is of quality, and of empathy you put, that is the feeling of or listening or putting yourself, and of course the assurances so all these are necessary as fairness, justice, and equality. Next. This person, healthcare professional, addressing moral dilemmas in patient care. It also balance competing interests. The health professionals balance competing interests such as patient autonomy and the physician's duty to do good. So all these ones are guiding principles for the principles we mentioned, which are the most popular principles in management. Next. These are some of the examples of the ethical dilemmas, ethical problems, ethical reasons, or ethical situation that will make someone think out of the box in order to do the right thing. For instance, number one, during a pandemic, deciding which patients receive scarce resources like ventilators. We've seen what happened during the COVID-19 pandemic era. We've seen it in the Western world, where I think the younger people were the ones giving the ventilators because of the scarcity, and the older ones were not prioritized. Maybe because they had their own life then, and maybe even their life expectancy is already close to end. So they feel the younger ones, if given opportunity, can now survive and also live their life. So the ventilators were rationed and given to, so is an ethical dilemma. The old ones also need to live. But then, this is what is happening. Then end of life care, balancing patient's autonomy to refuse treatment with the physician's duty to alleviate suffering. At times, patients will say, I want to end my life. This is my life. I don't want it. And so the physicians will allow me to die, to allow the patient to die without any treatment on the patient. So this is an ethical dilemma, even though he has the right. He mentioned what he wants, but can you allow the patient to die? So this is another ethical dilemma. But legally, when you come to legal issues, right to life, which is granted us by law, especially the Constitution under fundamental human rights, that you have the right to your life, and nobody should take that life away from you. It's your rights, God-given rights, and legal given rights, but then you have no right to take that life. That reason why if someone attempts a suicide, is going to go to prison. All those people jumping into lagoon, if they are caught up before they jump into the lagoon, they are going to face the wrath of the law, because you are trying to commit suicide, which is a criminal activities, except if identified through medical examination, maybe they have some mental problem, mental challenge, then the law, does not punish the mentally unhealthy person. So maybe it's as a result of that mental sickness. So this ethical dilemma, end of life, whether patients should be allowed to die or not to be allowed to die. So the doctors are usually in that dilemma. Then confidentiality, protecting patient confidentiality while disclosing information to others, such as family members or other healthcare providers when necessary. People used to have a guilt, especially the doctors, when they want to show that maybe the situation of the patient is beyond treatment, is beyond care. Maybe they are just giving him a palliative kind of treatment. But this is his own confidentiality. But you also want to tell the family members the situation so that they should not bother themselves thinking to take him to another country and spend their money while he's not going to get better. So you may now child, maybe the eldest in the family. So that's also an ethical dilemma, because you are divulging the confidence, the confidentiality of the patient. You are divulging the confidence which the patient has reported in you based on that doctor-patient relationship. But that has to be done. That is why if the doctors want to tell the situation, they look at the most composed person, the most, a senior person, or maybe the next of kin that is of matured mind and sound character, and also that person should be advised not to, divulge the information. As it should be strictly maintained as private. So these are also ethical dilemmas. There are even a lot of other ethical dilemmas. For instance, a patient, with a wound, come for treatment, and he was now telling the doctor that he got the wound through armed robbery. So doctor is not a police. He treats the patient, and I didn't even come with the police. But then should the doctor go ahead now to divulge the confidentiality? Well, if he does divulge, then definitely he is exposing the secret of the patient, and of course. But if also he refused to divulge the information, to disseminate to the appropriate people, or maybe the management, then that means he's an accessory to crime. He's supporting criminality and, of course, armed robbery. So these are all ethical dilemmas you find yourself in, especially if it's a traffic too. When someone maybe got fallen from a theft attempt, and he's rushed to the clinic, and he himself was saying that we went to thief, and that's where I sustained this injury. Then it's left for you now to think whether to tell the police or to keep it as private as it is, because it's your client and you are trying to maintain the access of confidentiality. But if you maintain it, it's going to be an accessory to crime. You are supporting and hiding a criminal, and if you expose it, then you are also divulging the information based on client's relationship, etc. So all these are ethical dilemmas. Next, cultural sensitivity, understanding and respecting cultural differences in healthcare practices, beliefs, etc. So these are very important. You have to respect cultural differences of people. You have to treat them based on their culture, because culture is very sensitive. And so these are also ethical reasons. Of course, we move to the promotion of diversity and inclusion. Then cultural sensitivity is one of it. Then we have equitable access. It shows inclusion. Then you have language accessibility, providing language interpreters to interpret, the condition of the patient or client in order to know how to take care of him. That's the reason why even in research, your questionnaires can be even translated into the local language. And of course, representation in leadership. All these are part of inclusiveness. For instance, in some countries, for those of you that have traveled out, you find out that, for instance, UK is one of the most diversified also and cosmopolitan in nature. It has cultural diversity, cross-cultural cultures, all in abundance. Therefore, find out that it's a policy of the government that in every office you go, there is some inclusiveness. There is some at least you must have one Black person in the office. So as to avoid, discrimination. If maybe as a Black person you go to one office, maybe someone may not treat you well, and you too, you might feel discriminated. So it's part of equality and a kind of policy that there should be a kind of inclusiveness of all people in order to, provide service. Then representation in leadership, that's part of the example again. Even in representation of leadership, there should be inclusiveness. There should be inclusiveness, encouraging diversity, leader to reflect the demographic of the community and ensure that diverse perspectives are represented during decision making. So all these things highlight the kind of inclusiveness as ethics. Not.
No, it's just that. Which one we can?
So ethics ought to be ethical, as I've mentioned before. There should be inclusiveness too here, by even involving community, to participate in what is happening in the audit process, so as to ensure transparency and accountability. It should not be the self-auditors only to, punish, to correct, but there should be community representatives to know and also to ensure compliance. Next. So these are just the type of audits, and we are more concentrative of clinical audits, which we have mentioned before. Physiotherapy audits, radiology audits, medical audits, etc. So these are the ones most relevant to healthcare organizations. And of course, financial audits are different, which they audit the accounts and to ensure transparency and accountability and judicious use of financial resources of the organization. Next. There's also operational audits. You audit the operations, kind of check and balances, or the checklist, etc., to ensure that organizational processes and resource utilization are done very well. Then you talk of compliance audits again. How well regulatory requirements. For instance, the Medical Rehabilitation Board of Nigeria can do compliance audits to see how much people have complied with licensing and how much people have maintained the accreditation standards of the board, and of course to also show that people are operating with the required skills and knowledge and certification. So all this can be done under compliance audit. Next. Information technology audits too is assess the security and efficiency of healthcare IT systems, especially ensuring electronic health records system meet data protection standard. Data protection standard, yes. Actually, electronic health records need to be protected, because if not protected, someone may have access to the patient data and compromise even the database and even substitute it with the wrong information. I think of recent, I've heard the president of the United Nations was complaining about ransomware attacks of many hospital databases, across the world. It's not more than 3 weeks when I had the president of the Secretary General of the United Nations mentioning about the ransomware attacks of some hospital databases. You can imagine if the bad people, get attacked the databases and substituted wrong information, right information with the wrong ones. What's going to happen in terms of treatment of patients? That's going to be dangerous. That's the reason why it may even lead to what we call medical identity theft. Whereas the medical identity theft in the IT world and the healthcare system is a kind of theft of identity of people in order to use it for a wrong purpose, in order to get a claim. For instance, you get a large data a reform for is provided. Then we also have the need for safeguards as far as IT protection is concerned. And basically, there are 3 fundamental requirements in safeguards, and that should be data should be always available. It should be reliable and it should have also integrity. Availability of data, that means anytime you want that clinical information in your database, it's available. It's not missing or it's not compromised. And of course, integrity means the data or the information that is in your database, it has an integrity. It can be used for clinical decision making. Then reliable. Then that means that data also should be reliable. There should be reliability. These are three. Then for you to ensure that, you need three safeguards. You have physical safeguards, you have technical safeguards, and you have administrative safeguards. The physical safeguard, where you have your database, make sure it's always have in key. You lock it. It has burglar. People should not access it. You should also make sure that it's operating within the right temperature, because when systems are operating in a very hot condition, it damages the system. Make sure that the staff clean it to avoid dust, etc. These are part of the physical safeguards to maintain. And make sure all the connections, the circuits are well fixed to avoid. Then the technical, you should have good passwording. The strong password is said. They said is the one you combine digit with a kind of alphabet, and it's long so that it becomes secured. Then you also need to have antivirus to protect the data, because at times it's the virus that will destroy the information that is there. They said the virus means vital information resource under siege. So that vital information resource in your computer is being compromised. Therefore, you need antivirus to protect that. You also need a kind of biometrics, whereby thumb, can be used to access the data, or facial recognition, etc. Then you need maybe another form of encryption, to support and secure your information in your clinical databases. Then the administrative safeguard means you should have an administrative protocol. You should have a policy. Unauthorized person should not be at that place. Maybe someone should not enter with his own personal flash, because if someone can copy the whole of your information in a flash and move out with it. So these are part of administrative safeguards. And also policy of confidentiality. Whatsoever the staff seen in your database should not be treated, should not be discussed outside. And you should even try to make sure that your computers in the clinics, in the hospitals, in the departments, is not being used for personal purpose. It should be only for official or clinical purposes. No Facebook on it, no WhatsApp on it, no any typing personal letters on it. Only official or clinical matters that relate to the place of work is being used. So this will ensure a kind of administrative safeguards to secure, in addition to safeguards for the physical. Evaluate integrity and competence of such activities. Example, ensuring clinical trials follow ethical guidelines. This is what leads to a kind of ethics committees in a hospital, which deals with clinical trials. It deals with also researches, whether medical students, physiotherapy students, and of all professionals, healthcare professionals. It also deals with multinational research, which involve ensuring those 4 basic principles of ethics are maintained: principle of beneficence, principle of non-malfeasance, that is not doing harm, principles of justice, and principle of autonomy. That is the basis of which is being considered. All other things can be broken down based on these 4 principles to ensure that things are well done with integrity and with great compliance. Next. Methods of audit. You can also do the audit in your own clinic, in your own department, in your hospitals, and what have you, depending on whether it's going to be a prospective audit, whether it's going to be a concurrent audit, whether it's going to be a retrospective audit. Mostly, when we say prospective audit, it has to do with a future audit. When you want to do audit of a patient care services with an aim to anticipate and prevent potential issues. That is even before the patient comes. You have to do the audit, you have to arrange how it's going to be done, how to avoid, wrong approach to the audit. That is preparation audit. It has to do with perspective. Anything prospective has to do with the future, and anything that is retrospective has to do with the past. So retrospective audit means considering the previous patients and assess how you treat them, how you diagnose them, how you discharge them, and how satisfied they were, and the resources you use to treat them. Did you use the appropriate resource or equipment, or did you refuse to do it when you have that alternative? You have that opportunity to use them. And what was the resultant outcome when you didn't use the equipment that you're supposed to have used? Was it better, or it was worse when you didn't use it? So all this need to find out in order to correct yourself in the future. This has to do with review the previous record. That's why it's called retrospective audit, because it has to do with the past. Then we have the concurrent. The concurrent audit is the type of audit you do when the patient is already receiving the care in your facility, in your clinic or hospital. You do that by kind of interview or a survey. You give him a form to fill, and the variables there should be, or the constructs there should be what satisfaction he has or he doesn't have, or whether he has been attended regularly or he's not been attended, whether it's comfort of the environment, whether he's being discharged when he was supposed to be charged, whether he was given opportunity to know the course of his care, whether people are responding to him when he needs. All these things should be the kind of thing that should be on the questionnaire to ask, or even in the interview to ask him. And this should be analyzed, to know whether the right thing is being done or the wrong thing is being done, so as to correct. So audit can be prospective for future, it can be retrospective for discharge clients and patients, and it can be also concurrent while the patient is still with you in the clinic, hospital, or something like that. Next. So these are example of importance of audit. It ensure patient safety, improve patient outcome, is increases efficiencies and effectiveness, and also improve quality of care of the patient. So these are basically some of it. Promotes accountability and transparency, and of course, it optimizes the use of resources. Because part of the definition we said is the systematic analysis of the quality, systematic analysis of the method of treatment, diagnosis, and the procedures, and of course the use of resources and the resultant outcome, and patients, etc. All these components need to be measured and assessed. So, so it promotes accountability, it enhances patient safety, and of course optimize the use of resources. Next. It also supports accreditation and certification. When you are doing audits on time. That is more conspicuous. For instance, like also reduce medical errors. And when it reduces medical errors, of course, it fosters continuous quality and improvement. And it also improves clinical governance. Of course, it reduces the chances of litigation and medical.
I see you.
Next. So it also enhances person satisfaction. And that's the essence of audit, of course, to find out the level of patient satisfaction. So it enhances patient satisfaction. It also supports research and development, because audit itself is a product of research. You can even publish your audit findings, as part of it. Also make things, in order to facilitate effective research, because with auditing, you find out the lapses and you also bridge the gap. And of course, it makes the place more functional. Next. So a culture of improvement embraces the audit. By embracing audit, healthcare organization can cultivate a culture of continuous improvement, ensuring high quality patient-centered care. This approach not only elevates patient outcomes but also strengthens trust and accountability across the healthcare system. This is just a summary of what we've said before. Next.
This is the last slide.
Okay. Thank you very much for your attention. I will now entertain questions, if there is, depending on the arrangement of my host, if that's part of the arrangement. Thank you very much for good listening. I really appreciate your kind attention. Thank you very much indeed.
So if
Hello.
Assalamu alaikum. Dr. Hafiz, are you online? Like the presenter is finished. Maybe you should coordinate, like Dr. Samani is not online.
Assalamu alaikum. Is it period for us to go on to ask questions?
Yes, you can do that. Yeah.
All right.
Yes, I can entertain questions, actually. There is.
All right. Thank you very much, Doctor. My question is this. For a clinical audit to be conducted, does it has a particular period of time, like maybe it should be 1 month period, 2, 3 months? I just want to get more clarity on this. Thank you very much.
Thank you very much. Can I answer the question one by one, or I should entertain all the questions, then I answer them subsequently? I don't know how much better to be done.
Dr. Hafiz, are you there?
Yes, you can answer, sir.
All right. Basically, I've spoken about three types of audits approach: prospective, retrospective, and concurrent. Then I also want to add that in audit, you also have what is called audit cycle. That is the cycle the audit should follow. Then under the prospective audit, this has to do with preparations for the future audit and how the audit should be conducted very well. So I think within that approach, we can be able to fix the nature of the or the period the audit to be conducted. And also a basis for convenience and how best the audit can be conducted. So you can decide under the prospective audit when the audit is to be conducted, for how long period, and also for what diagnosis or for what nature of a medical condition or physiotherapy condition that of the patient that it can be selected and to form. So that's prospective audit. Then again, we have audit cycle. In audit cycle, first of all, what you need to do is to establish a criteria. So what is you find out the criteria for the audit that you adopt the audit criteria by saying this is how we are going to do it. It's going to be based on 6 months, period, attendance by patients, or it's going to be based on so condition, etc. So you have to establish a criteria. Then from that establishment of the criteria, then you select, a topic or a factor to consider in the auditing process. So then from there, you also now, after selecting the topic, you now implement, the audits. Then you now, it's going in cycle. Then now you now evaluate. Then you now review. Okay, then it keeps on going like that. So in prospective audit, you select the criteria, you select the period of the topic, you also the period of the audit, you also select the condition you are going to audit, or maybe the case you're going to audit. And the same thing when it comes to the establishment of criteria, you have to now identify the criteria you are going to follow in the audit. I have said all this depends on your situation, depends on the problem you've identified. Usually there must be a problem that also will be part of the consideration for the audit. Audit should be a periodic process. It should be like a policy that within every 6 months or within every 3 months, there should be audits of services we've rendered, which could be a kind of retrospective in nature, or it can be a questions directly and get your own data through questionnaire or interview in order to analyze. I don't know if I've answered the question. Thank you.
Thank you so much, sir.
Any question again? Next.
Hello all, you can ask your questions or write it down in the chat box.
So if you have any question or comment, please do it.
If there are no any question, maybe you can make a contribution if you have, or comments or observation. You're all free.
Dr. Timothy, like you wanted to say something. Let's hear your observation or comment, especially considering your in-depth interest in this field.
Not really. I don't want to say anything anyway. It's all interesting, and as the CEO, it's a very interesting topic to participate in. So I think I'm enjoying the topic. Thank you.
Maybe you should get prepared. Maybe you'll be our next presenter.
God's willing. Thank you.
All right, thank you. Other participants, please, not only question, you can contribute or forward your observations regarding the presentation, in writing or via mic. Thank you.
Okay, someone is asking, is there an operation guideline on when to divulge a patient's data? Can the court, the law enforcement agent, or a panel of inquiry demand a physiotherapist to disclose confidential details of his patients? This is a question from Keltumalawan.
Yes. Under conditions when a patient information can be divulged, we have one, for instance, based on court order. Court order, that is order from the court. In fact, we have two types of court orders that may come from the court to the hospital. For instance, there's one we call in Latin, supona ad testificum, and then the other one is called supona duce tecum. In supona ad testificum, it's even the physiotherapist himself or the health information officer or a medical doctor or a laboratory personnel that may be asked to present himself in court as an expert to give a testimony regarding a case that is before the court, because the judge is not a medical personnel or a specialist in that area, so he needs someone that has that knowledge and skill. In this case, this person with knowledge and skill is the person that is assumed to be even the standard of care, because the judge now will not rely on your document or standard of care because it's not vast in clinical matters or healthcare professional matters, but he will depend on the expert testimony of that professional, which he will now take in as his record, because the expert now will become the standard of care, and the action of someone that is accused, for instance, of a negligence or malpractice will be measured based on that standard of care. That is who is the expert. So if the expert is asked and he mentioned the procedure that's supposed to be done as a standard based on his experience and knowledge and qualification, then the judge will now measure the action of the accused or person before the court for doing the wrong thing. So if his action is equal to the statement of the person giving the expert testimony, then he did not do any negligence or malpractice. But if it is short, then it may assume that he has done the wrong thing, and the court may decide to punish him the way it feels appropriate. That is supona ad testificum. Then when we come to supona duce tecum, this is what concerns with the information, okay, which a court may ask, a healthcare professional to bring. Usually, there are people that are supposed to keep the custody of the information, but they cannot give that information directly to the court. It has to follow the administrative requirement given approval by the management of the hospital or the clinic for that thing to be done. Then it can be taken to the court as evidence, because usually court make use of documented evidence, to apply their own evidence law. They need information. Now they even accept technological information or written information as an evidence to be admitted in court for judgment. So that can be done by providing it to the court, because nobody is above the court. We are all operating based on the rule of law. Even the president, if the court asks him to go to the court with a document, he must go. What about healthcare professional? So court is above everybody, is the custodian of our equity, and is trying to balance the society. They say they are engineers, they are social engineers. Without the law, without the courts enforcing the laws, then there will be anarchy in the society, and things will not go the right way. The society will live like a jungle, where the fittest, the strongest, takes all the day. So that's it. Another reason not to the court this time around, you can divulge information of a patient if police request it. The police can even get an order from the court to get the information as well. So that's it. And also, when there is an infection, definitely you have to communicate the information about infection that may even affect the whole community, because there is a concept that public good or public interest should be the watchword. You cannot protect a single patient because you don't want his information to be divulged and then allow his own disease to affect a larger community. So it is called public interest. So it can be divulged based on higher duty, which is public interest. A higher duty here means the interest of the general public is more regarded than the interest of a single patient. And of course, if the patient also is a criminal, someone has gone to steal something and he fell down from the fence, and you heard in the radio that someone has just with social color declare police, because if you don't do it, you may be an accessory to crime. And that's one of the moral dilemmas I've mentioned, whether to divulge the information or to keep this information in order to protect the confidentiality of the patient. So, thank you. Next. Above all, when we come to, maybe let me just chip in here, when we come to ethics in healthcare organization and what have you, because our course module here is about health management and administration. You should also mind that even though in healthcare we talk about beneficence, justice, non-maleficence, and autonomy, in administration, in healthcare, there's also ethics in public service, ethics in public service. For instance, what are the ethics of a public servant or a civil servant? Because it's an aspect of administration too. That is, for instance, number one, you should show efficiency. Number two, you should be honest. Number three, you should show morality. Number three, you should be punctuality. You should be tact. There should be industry. Okay? You should not involve yourself in forgery, embezzlement, fraud, all these ones, because some even fall under misconduct and gross misconduct. So ethics in civil service is about promoting good image of the service, etc.
There's also another question. Thank you very much. How can you relate leadership and management expertise with patient-centered care, as patient-centered care is highly related to professionalism?
Patient-centered care and management, because patient care is related to professionalism. Okay, I think the relationship there I mentioned is that as a manager of healthcare organization, your leadership and management expertise should try to improve patient care, because healthcare organization is a patient-centered organization. I've mentioned in the previously that healthcare organizations differ from other organizations in the sense that a hospital organization is not a biscuit industry, it's not a plastic industry, it's not a tire manufacturing industry, it's not a soft drink industry, where if there is a problem in the process of production, you only declare damages of the goods you are trying to produce, or damaged biscuits. And in some cases, even the biscuit might be utilized. It can be still, it can be eaten, only that it cannot be packaged properly. But in healthcare, as a manager and leader, you should consider the healthcare organization as a patient-centered organization, where your expertise and leadership should focus on improving positive outcome of care, because you are dealing with human beings. If there's any mistake that goes in your leadership or managerial application, it will bring about a kind of a disaster to the patient in terms of maybe incapacitation or even death or discomfort of any nature. I think that's how it's being related to leadership and management. Thank you.
Thank you, sir. There's another one. It's asking, if a husband is a HIV patient, can you notify the wife if she's not aware of it?
Are you sure this is not a domestic? Oh, you mean who should notify the wife?
The doctor.
Usually HIV patients go through a special area where it has to do with counseling. And from that counseling, I think they will have a breakthrough on how they should relate it to the wife. Because actually, counseling is also a professional area. It's not everybody that jump into clinical counseling and what have you. They are specialized in nature. So they also have their own training and approach to counsel a client regarding his own status, and also how to relate to the family as well. So that's it. But actually, when we go through the principle of ethics and principle of autonomy, you have no right to disclose the information of someone to another person, because that person, you are treating him in his individual capacity based on his own autonomy. You have to respect his autonomy. You have to show that whatsoever information he gives you is in confidence, as we mentioned, privileged communication, privileged information, and privileged and professional confidence. You communicate because of your privileged status as a professional, so you feel free to communicate with you. And you also obtain the information on a privileged basis, because you have no right to get information about him if not because you are professional. And for professional confidence, what gives him the confidence, to relate with you and to tell you his secrets, a secret that he did not even tell his mother, his wife, and maybe his imam or his pastor? Then why then are you going to be the person in a rush to tell his wife? I think there should be an institutional arrangement. That's the reason why the moment someone is declared HIV, he goes through counseling, and in that counseling, maybe they have a body of approach to which they can communicate to the spouse as far as the status of that person. And I think the doctor should be very careful on how to divulge information of his own client and patient. That's not his own major responsibility. It's not his own major responsibility. His own major responsibility is to provide care to that patient and also maybe send him to the counseling support unit for them to take over that and link up or to link up even with the family. We even have the medical social welfare that can all come in order to support that situation. It's more of social situation rather than clinical situation. That's my view on it.
Well, thank you very much, sir. And the last question I think here is, if for instance, a patient came and he is a criminal, do you first treat him or call police before giving treatment? Thank you.
This also not your role to call police, because you must have breached a lot of protocols. That reason why in the past there are even police station in the hospitals where even accident victims are first of all being escorted by the police, so that you should not bring a criminal, so that a criminal should not come and have access to healthcare when he's supposed to be arrested. But even of recent, the government has now removed that clause that even victims of gunshots can now be treated, victim of accident and gunshots can be treated without police escorts, because people are dying. And in some cases, it's not even armed robber that sustained the gunshots, but rather maybe a victim of banditry or Boko Haram attack, or victim of farmers' herders clash that may even come to the hospital. So if you denied him the treatment, he may end up dying. So that's the reason why the government said now, no, allow him to have the treatment, irrespective, before certain things can be sorted out. So even in a situation where you are trying to free yourself from being an accessory to crime, it doesn't mean you should, divulge information directly to police. There must be some administrative protocols. You may have your head of department, and the head of department may also discuss with the boss, if it's a clinic, maybe to the head in the clinic, or to CMAC if it is a teaching hospital, and the CMAC may even consult in CMD, and the CMD may even intimate the security, and the security may also be vigilant, and of course even the legal department may even come to advise on what best to do. But don't rush to say you call a police and what if it ended up it's not even true? You just said it based on joke. He may also sue you subsequently for damaging his character or whatsoever. Or he may say you did not even hear what he said. You didn't say he's a criminal, but you assume he was a criminal. He was just making reference to somebody, but you did not listen carefully. So that means you may end up also in court if he sue you, because as a patient has rights to go to court, and he can also be taken to court. And in a situation when he sues, he may not even sue you as a person, because you are just a hired staff. So he may sue the hospital that employed you. That reason why in legal issues, that what is called vicarious liability, where the liability may be shifted from the person that committed the offense to the person that employed the staff. So in this situation, the hospital might be sued for employing someone that damaged the character of another patient. and subsequently, the hospital might be fined, and the hospital must pay the fine. And they have to now come back to you and use you as a scapegoat. So that's the essence why hospitals should always employ the qualified personnel. And this qualified personnel is also assumed to have learned ethical and legal issues that relate to his own profession. That's the reason why you see ethics and law are part of most of the curriculum, because a situation when you may find yourself in the law court, in the court of law. I mean, for some actions done. So I think you don't have direct relationship with the police. You don't have direct relationship to say that there are protocols, there are departments and units that need to collaborate, but you have the duty to report to your higher superior officer, and the superior officer should also contact the relevant stakeholders to let them know the situation. Thank you very much.
Thank you, sir. Any other questions? I think we have exhausted the question. At this moment, we want to sincerely thank you, sir, for well delivered presentation. I'm sure you've done justice to the facts, and we should do in future workshops similar to this one. Also, thank the participants for attending. We are now taking a break for close to an hour. Around 2 o'clock, we should check the second aspect of the workshop, which is on healthcare financing. I have how much time. We'll see you at 2 o'clock for the continuation of the lecture. Thank you so much, sir.
Thank you very much. Thank you for the privilege. I appreciate you all, and thank you very much indeed. Bye-bye. Thank you. Bye.
Supervisors, because yeah. Ainda akan mesti pada Asia.
No, na get mechiri emechi now.
It's nothing like brigada. Brigada.
Ma?
All right.
Well done.
No work today. No physio for Ottawa today.
No.
Every left. No.
Don't go back to bed.
No, I can't find it. I think today I mathematics exercise. Not unpredictable exercise.
Now you go tell us which one we go do, abi?
Sometimes sometimes when I have a counter opinion, so one group is sometimes you read. I know that's what you want to do. You do really busy. But whether I keep the back side. He said that since that day became, people lost some Tuesday. I will do that gross walking, going back, going back to the bed. It was a hectic night. That's night was yeah.
So when the tell physio now say pay, they pay you. Physio, that physio wey go do a pay with something.
So thing was not. And second day was I was only able to move from here to the room outside and come back. I was still out Thursday, I will do it. Relax, you are back. Careful. And what beside maybe you look at my life to do. I have yesterday. After I was telling you that my own conditions about the school. I don't know what you have in mind. Maybe you want us to go on the behavioral side. I don't need to have. So tell me about
Not really. No, I wasn't planning to do that one. You know, you mentioned that Tuesday that you would do it on Thursday.
Yeah.
fair and compassion. The mother is a happy woman. She's about 400. Not 400. My zero is bad. My zero and 4 were like, I see that they were not. I'm with zero. But if you want to back, that's what they don't write to so you know why is very low. That F is
Pack, I need to pack up our colleague.
Did you let that tell that man that what is mommy? No. I was a lot of but you know what he said. He opened the door. You have a 1,000 men. He marched them up to the top of the hill and marched them down the hill. No, they can't put that one for us. They said that no. In the old grand book of God, I know that Duke. Ina bayan haka Anthony. Ina naka pencil. Wani ba nan za ba? You have your own book ba? I have to go for my class. Anthony, I thought you have pen. Start writing. Give me a J. Where's that kid, sir?
Don wancan karan ma a 10 riyal suka mai da ni. 10 da yau kuma.
Oh, yeah. I think I have one. It says. Give me a J.
It is already fast 2. So we're supposed to come in here by 2. I don't know what is delaying the.
Kana ina ne? To, shi ke. Za ka shigo ba? To, shi ke. Wane ne? Now?
This is me, I've never felt it.
When I was in school, then I wanted
For the
to
experience.
come, but I didn't have opportunity.
I've never felt
Yake masan ya zama buru a Atago. Ina kokarin kira ne yanke.
Ni matar ta ga kamar yarinya.
Good afternoon, everyone. We are very sorry for starting late. Our facilitator has joined us now. So without wasting much time, I want to hand over to Doctor from the Economics Department of Bahrain University, Kano, to take us through healthcare financing. Welcome, sir, and you can start.
Thank you very much, Doctor, for the introduction. I will once again apologize.
It's like we can't hear you. Maybe.
Oh, really?
You connect your mic or something. You are muted. You need to unmute, please.
Yes, I unmuted. Can you hear me now?
You need to unmute.
Can you hear me now?
Yes, sir, you are audible.
All right, thank you. Okay. Is it okay this way?
Yes, we can see you, we can hear you.
Yes,
all right,
please.
thank you very much for that. All right, I apologize once again for being terribly late. Sorry, this is the life of an academic. We just finished examination this afternoon, and I have to take some break, maybe to pray and eat something before I join you guys.
You are unmuted, but we can still hear you. I don't know whether it has to do with your.
Dr. Samani, I don't know whether it is from your side, but we can hear him.
I can see you are unmuted, but
I can hear him.
hear anything.
Yes, we can hear him.
Probably
what about this? Can you hear me, please?
We can hear you,
Yes,
sir.
sir, we can
Maybe it's
hear
from
you.
Dr. Samani's side. Yeah.
Okay, maybe you need to take
We
your
still
side.
can't hear.
We can
Dr.
hear you, sir.
Samani, maybe you are the one having a problem, but we can only see him and hear him.
Exactly, we can hear him. Yeah.
Yes, we can hear him.
See you, but we can't hear you.
Please, someone should call him and inform him
Yeah,
that
you are
he's
hearing
not
him.
even hearing what we are saying.
They can hear you. I think the problem is from me. So you can continue.
We are hearing Dr. you, Jibo. You can just continue.
Okay.
I will still apologize again for being terribly late. Thank you very much for the introduction. I'm Muhammad Ibrahim Abdullahi by name, lecturer with the Department of Economics, Bayero University, Kano. I'll be taking us through this module on healthcare financing. You know, healthcare financing is one of the major pillars of providing good health and achieving universal health coverage specified by the United Nations, of course, and the World Health Organization, that, of course, the greater part of percentage of population of the world should have what we call universal health coverage by the year 2030. And without a very good healthcare financing instrument, definitely such a goal cannot be achieved. So this outlines a bit the importance of healthcare financing, but in the process of discussions, we elaborate on this importance. The next slide pinpoints the outline. Yeah, thank you. The outlines for my presentation. So mastering these terms is very important for the understanding of the presentation, actually. And then after defining terms, then we talk about healthcare financing and its relationship with universal health coverage. What health coverage, universal health coverage is all about. And then, of course, how is it related to strategic healthcare financing? And then we talk about the specific 3 pillars of healthcare financing. The issue of fundraising, the issue of health or risk pooling, and then lastly, the issue of strategic financing of healthcare services, and then we conclude the presentation. The PowerPoint you have here actually is not really perfected, but it will be as a guide for this presentation. Maybe subsequently I update it and take care of any possible spelling error and what have you, because I just finished it this morning. So definitely I was in haste to come to school for examination, and there might be some little omissions or commissions here and there, but I will see how I can update the PowerPoints and then send it later. Luckily enough, I went through the list of participants and I realized that some are already experts in healthcare financing, because I could see some of our master's students or master's graduates of health economics here in Bayero University as part of the participants here. So I believe some have the expertise, but notwithstanding, I believe there are some that are new to this field, a very a wide field of healthcare financing. So let me see how I can balance the presentation between maybe carrying the beginners along and of course not disappointing the advanced learners, so to say. I will try my best, but I want the presentation to be interactive in the sense that you can interject at any point you feel you have anything to contribute, whether an observation or a criticism or a question. I don't mind, depending on what time allows. All right? So by my glossary of terms, I begin with the definition of healthcare financing. And healthcare financing is generally a concept that has to do with generation, pooling, and allocation of financial resources in the health system. This is generally what entails the healthcare financing: how you generate funds, how you pool the funds together, and then how you allocate them for strategic financing or strategic purchases of healthcare services. This is generally what is called the healthcare financing. Therefore, whenever I talk of pillars of healthcare financing, these are the three pillars: the issue of fundraising, the issue of pooling, and then the issue of purchasing. Because if you raise the funds and of course you fail to pool it so that you can make a larger or bigger purchases, or rather you spend it in such a way that it will not serve the purpose, then the healthcare financing will not be achieved. So all these three must have to be very efficient for us to achieve an effective healthcare financing: generation, pooling, and allocation of resources, as we will see subsequently. And generally or traditionally, we say healthcare financing is divided into two: the public health financing and the private health financing. The next slide tells us more about public health financing, which we all know that is nothing but the government health expenditure. Can we go to the next slide, please? The public maybe the person operating the PowerPoint cannot hear us. I'm not sure. Can we go to the next slide, please? Okay, can I continue?
Yes, sir.
Okay, I want to carry us along. That's why I want us to be following the slides so that people have a better understanding. But unfortunately, from the control room, I don't know, maybe they have some technical issues. I'm not sure, but I'll continue because of time constraint. Sorry for that. Maybe when they settle their issues, maybe we catch up with them or they catch up with us.
Yes, sir. I think you can continue.
All right. Oh, Dr. Major, you are among.
Yes, sir. Welcome.
There are experts in the room. Thank you.
We are students always.
All right, the healthcare financing or expenditure generally, because expenditure and financing are used synonymously in the literature. So healthcare financing is divided into two traditionally, the public and the private, though we are going to talk about further categories, but broadly we see them as public and private. Public health expenditure, as I said, is nothing but the government health expenditure, right? This is part of government expenditure, general government expenditure, both recurrent and capital, of course, and all its agencies, including ministries, departments, and of course, agencies of government that may be part of their expenditure that is allocated for provision of healthcare-related goods and services. And this may include extra budgetary allocations, such as compulsory health insurance, like the case of NHIA in Nigeria, or state health insurance agencies within the states. These are all part of public health expenditure, though there are contributions from the participants, which are normally the workers of government, but I believe government also put in some money for running such social insurance agencies, and that makes it part of the public health expenditure. All right, and when we say the rate of government health expenditure, when we are talking of the rate, we are relating the, or we are expressing the government health expenditure in relation to the total expenditure of the government. This is generally the percentage of total budget that is allocated for health. The percentage of budget country that is allocated for health, this is what we normally call the rate of expenditure on health. We all know about Abuja declarations of the African countries that propose 15% of budget of every country to be allocated for health sector, so that of course there will be health coverage in the country. Unfortunately, in Nigeria, we have not been having even up to 5%. Mostly the budgetary allocation for health, particularly at national level, ranges between 4 to 5%. Hardly you see it up to 7%. It's only in the case of state governments that you realize that some states may even allocate up to 20% of their expenditure, perhaps maybe because they are not making provisions for security. And that's why if you look at federal government, you see most of our budgetary expenditure, in fact, defense and security consumes the largest part of our federal budget, so to say. So the Abuja declaration of 15% hardly be achieved in Nigeria over years. The other type of health expenditure is the private. We talk about public, the other one is private. And private, this of course includes all form of direct expenditure by households or by patients and their relatives in the course of seeking healthcare services. It includes the out-of-pocket spending by individuals, the contributions to insurance, and of course, some charitable donations to maybe endowments or foundations for healthcare provision, and of course, the direct service payments by private corporations, large companies that pay directly for their workers for the provision of healthcare services. This definition is given by the World Health Organization. So generally in a country, we say that the total health expenditure will comprise of the public health expenditure and the private health expenditure. So when you take the sum of the private health expenditure, and all right, thank you. The slides are back, but we are still in maybe around slide 4 or 5 or 6, thereabout. Yes, maybe private health expenditure. Yeah, the next slide, please. All right, so you can see total health expenditure comprises of the public health expenditure and the private health expenditure altogether. The two will give us the total health expenditure in a country. The next slide is on universal health coverage. Of course, this is a very much universal. The concept itself is universal, just like it is called universal. All right, meaning everyone knows about health, universal health coverage, particularly those we people that operate within the healthcare system. The World Health Organization defines universal health coverage to mean all people have access to the full range of quality health services, not only health services, but quality one, which they need when and where they need them without financial hardship. That means the concept of health for all. You know, actually, poverty can be a very much detrimental factor in accessing healthcare services. So universal health coverage as a concept, or rather as an activity now, seek to provide health for all. Whether you have money or not, whether you are poor or rich, whether you are sick or healthy, you access the quality healthcare services you need as at when you need it and where you need it without exposing yourself to any financial hardship. We subsequently look at what we mean by financial hardship, where we would define the concept of impoverished health expenditure and the concept of catastrophic health expenditure. So universal health coverage covers all such essential services, from health promotion to prevention to treatment, rehabilitation, and palliative care. All forms of healthcare service provision to be covered, and of course, without exposing one to financial hardship. And that is why you see the United Nations Sustainable Development Goals, SDGs, itemize the goal number 3 that the major slogan for that goal is health for all, meaning you achieve universal health coverage in all countries in the world by the year 2030. So you can see the achievement of universal health coverage varies among countries. We can see Canada to the tune of 91% in 2021. I will try to update this because I know now Canada has achieved almost 95% universal health coverage. But in Nigeria, the same period, the universal health coverage was only 38%. And ordinary Morocco here in Africa was recording 69% in the same year of 2021. So you can see where Nigeria is. And of course, maybe when we come to discuss issues of raising funds for health, we see why Nigeria could not achieve much as far as universal health coverage is concerned. Only 38% of its population that is covered as far as universal health coverage is concerned. That was in 2021. I don't know exactly what's the figure now, but it was 38% only in 2021. So I don't know, I raised a question here, which is a teaser. We are coming back to that question, whether we can achieve universal health coverage with the prevalence of out-of-pocket expenditure that we have in Nigeria. Another concept is that of financial risk protection. This is very important concept of World Health Organization that, of course, you know, when we say financial risks, is the possibility of losing money or anything of value. This is generally what we mean by financial risks. So when we talk of financial risk protection, meaning that somebody be protected from financial risk, and it is defined by households assesses the needed healthcare services without experiencing undue financial hardship. And of course, one of the motive and the very much motive of universal health coverage is to achieve financial protection so that everybody can access healthcare services without being exposed to financial risk. And that is one major advantage, or rather goal, of universal health coverage. It is very critical in any healthcare system, particularly in countries with higher poverty rates, mostly low and middle income countries, to achieve or to have financial protection of the patients. So another concept that I want to talk about in the next slide.
Na yi going through ma ban ga wannan din ba, kuma kafin na wannan tun daga wannan ko ya za a masa wannan.
Are we communicating?
Ya ga suna tabbata kowa da happiness.
Yes, yes.
Yes, sir.
I just hear some noises from the background. All right. So we talk about catastrophic expenditure. Of course, catastrophic expenditure is technically defined as, of course, expenditure that exceed a defined threshold of household total consumption or non-food consumption expenditure annually. Let me elaborate on this. We all have our expenditures as households or consumers or people, right? And of course, we don't want out of that our total expenditure in the year, maybe healthcare provision to consume certain percentage beyond a given threshold. These thresholds were given both by the WHO and of course the World Bank. According to WHO, whenever you spend anything above 40% of your total income, then you are exposed to catastrophic expenditure on health. When you spend 40% on healthcare out of your total income, then you are exposed to catastrophic expenditure. And for World Bank, it is 20%, just 20% of your ability to pay. And what is that ability to pay? What is that ability to pay is the share of the capacity to pay. That is your income minus basic needs. Your income minus basic needs. So let me explain again. If you spend 40% of your total income, sorry, there is a mix-up elsewhere. Sorry, 40% of your ability to pay, or 20% of your total income. Ability to pay is defined as your expenditure after basic needs, the remaining income you have after basic needs. So if 40% of that goes to healthcare provision, then you are exposed to catastrophic expenditure. Or rather, if you take your total income for the year and you spend at least 20% or more on healthcare provision, then you are exposed to catastrophic expenditure. So this is the technical definition of catastrophic expenditure. It's just talking about sorry, am I back in the room?
You are back.
Sorry, I get a fluctuation of network. That's why. Sorry for that. So when households are spending more than 20% of their total income, we say that that is a catastrophic expenditure. And impoverishing expenditure on the next slide is maybe any health expenditure that can make someone to be poor. We know the poverty line of $1.9 per day, which is a global measure of poverty line. So if your expenditure on health will make you to incur expenditure that will throw you below maybe $1.9 per day, then out of your income, then that expenditure, health expenditure, is impoverishing. So these two unwanted situations will have to be avoided by the universal health coverage. Then the out-of-pocket expenditure, this one I don't have to talk much about. You know, this is direct payment for healthcare goods and services from the household primary income or savings, where payment is made by the user at the time of the purchase of goods of the or the use of the service. So we all know out-of-pocket expenditure, which is a direct payment of healthcare services by the patient or by households. Of course, excessive out-of-pocket expenditure payments may hinder access to healthcare service. Why? Because if you spend much on out-of-pocket, or rather for poor people that will not have enough income to spend much out-of-pocket, they can hardly access healthcare services. And that is why it's very important for a country to have a pool of resources from which the healthcare services will be purchased or provided. Apart from out-of-pocket expenditure, and then we talk about pooling of resources. Pooling is a core function of healthcare financing policy. Yes, and of course, pooling is nothing but the grouping together of assets and related strategies for minimizing risk. Of course, if you allow individuals to spend their monies out of pocket to access healthcare service, of course, there wouldn't be an effective quality healthcare service provision, as we can see maybe in some other countries or other jurisdictions around the world, where the healthcare provision is in its advanced stage. Countries like Canada and what have you. Hardly you see people spending in fragmentation. Generally, resources are pulled together for strategic purchasing of healthcare services, and that minimizes the risk of any unwanted healthcare expenditure. And of course, for the purchase, for the bulk purchase of the quality healthcare services, that the purpose of pooling is to spread financial risk across population so that no individual carries the full burden of paying for healthcare, according to WHO. If you pool resources, then the risk is shared. If someone is sick, and someone is healthy, that person that is sick will not only be the one to cater for the healthcare service. The pool resources will be used to cater for the services that the person needs at when needed, and without exposing such a person to financial hardship. And in such doing, you see, the entire population will be covered, and of course, we achieve the wanted universal health coverage. And it is one of the three pillars of achieving universal health coverage, as I mentioned earlier, the issue of mobilizing resources, pooling resources, and then strategic purchasing, which we are going to discuss subsequently. Of course, fragmentation is a situation whereby each healthcare service subscriber faces individually. And this exposes people to financial risks, and of course, even financial impoverishment. People can be poor as a result of fragmentation or fragmented purchases of healthcare services. Then we talk of strategic purchasing, which is the last pillar of universal health coverage, or the last pillar of healthcare financing. Purchasing is another core pillar of achieving universal health coverage. And of course, according to WHO, purchasing is considered strategic when allocations are linked, at least in part, to information on providers' performance. So you have to look at the performance of the provider, and then you have to look at the health needs of the population. And of course, you have to aim at achieving efficiency and equitable distribution of resources. And of course, managing expenditure growth. There are some elements here in this slide that I highlighted and make them in bold, that in strategic purchases, there are things to be considered. One, what is the provider's performance? The facility that you are going to subscribe, what is their performance in terms of the quality provision of care? Two, what is the need of the population? What are the types of diseases that should be covered, which are very much prevalent in the area that maybe the resources are pooled? Three, and what is the efficiency? What is the efficiency of the purchases? Efficiency here talks about minimization of cost. If, for example, there are two options to achieve a certain healthcare service, and one is cheaper than another. So we say someone is efficient if he pursues or she pursues the one that is less expensive. But somebody that chooses the most expensive channel or strategy or option, then we say it's not efficient. And of course, the issue of equitable distribution of resources in such a way that everybody gets what he or she needs as at when due. When we talk of equity, we mean all people, regardless of their health status or financial status, get the same quality care as at when due. If a wealthy person having headache and very poor and vulnerable person having headache at the same time, let them get the same quality of care without any differentiation based on their health status or financial status. That is what we mean by equity. And of course, managing expenditure growth so that there will not be escalating expenditure on health. So when you achieve these items, then we say purchasing is strategic. But there are purchases that are not strategic, obviously, particularly in the public sector. Mostly what governments do is very much extravagant to some extent, and sometimes they don't even consider what are the major needs of the society, and sometimes they are not efficient in the expenditure, maybe because of bureaucratic process and of course corruption that is very prevalent in Nigeria. But the issue of efficiency, you see, is very much far away from how we provide healthcare services in Nigeria. So now we begin the discussions on healthcare financing. Let's go back to healthcare financing and look at all the concepts maybe and the important issues that are related to healthcare financing. So I will say that we are done with the glossary of terms. We define many terms, including health financing, the public health financing, the private health financing, total health expenditure. We talk about the universal health coverage. We talk about catastrophic expenditure. We talk about impoverished expenditure. We talk about pooling. We talk about strategic purchasing. We talk about fragmentation. We talk about out-of-pocket expenditure. All these concepts are now defined. I don't know if we can move ahead or if there will be any intervention from any participant, please. All right, without any intervention, let's talk about healthcare financing now in detail. You see, healthcare financing, as given by WHO, is one of the major building blocks of healthcare system. Without financing, you can never achieve an effective healthcare. In fact, you cannot even provide resources if there are no financing. If you will not source funds and you will not spend funds, then how do you achieve healthcare services in the country? As we all see, because we are all health workers, we know these 6 building blocks are what the WHO provided as the healthcare healthcare system building blocks, that you have a leadership and governance which is effective, of course, and then you must have an effective healthcare financing, and then you must have health workforce like we people or you, sorry. And then you must have the medical products and technologies, and then information and research. This is the issue of data and documentation for research and informed decisions. And then, of course, the issue of service delivery. When you combine this, then these are the goals and outcomes. You have an improved health, right, in terms of individuals, and of course, for any participant or member of the community or society to access a very good healthcare services. And then you get a healthcare system which is responsive. And of course, you protect individuals from financial risk. Of course, then you get an improved efficiency in the health sector. So these are the building blocks of health financing. Of course, another chart here also provided by the WHO, that this is the role of healthcare financing in achieving universal health coverage. And we know that universal health coverage is one of the goals of the Sustainable Development Goals that are supposed to be achieved by 2030, even though Nigeria is still far away from achieving universal health coverage. We can see the role of health financing in achieving the coverage, right, within the overall healthcare system. The issue of revenue raising, the issue of pooling of resources, the issue of purchasing. And these are all pillars of healthcare financing, which will lead to service delivery and creating resources, and of course, even hiring for health workforce. And then from healthcare financing, you achieve the intermediate objectives of universal health coverage. That is the issue of equity in resource distribution. That is, everybody gets a fair share of resources in the healthcare sector. And you achieve efficiency because through pooling and strategic purchasing, you minimize cost. And that is how you achieve efficiency. And of course, you achieve transparency and accountability. And then lastly, the final goals of the universal health coverage, the issue of utilization, proper utilization of the health services and equipment, and then financial protection and equity in finance so that nobody will be exposed to any financial hardship because of services, healthcare services, and then lastly, to achieve quality care. So these are the optimum objective of universal health coverage. So you can see the background all relies on healthcare financing. Without effective and efficient healthcare financing, universal health coverage will be far, far, far from being achieved in any jurisdiction. So still, as far as healthcare financing is concerned, okay, I might migrate a little to discuss the universal health coverage. I digress a little to define the universal health coverage that I defined earlier as all people receiving quality health services that meets their needs without exposing them to financial hardship in paying for them. That is health for all. That is what we call universal health coverage. We talk about universal health coverage initially, and it is mentioned under Sustainable Development Goals, goal number 3, which covers good health and well-being. And of course, at the societal level, universal health coverage reduces inequalities by guaranteeing that everyone gets the good quality healthcare services they need, regardless of who they are, whether they are rich or they are poor, whether they are villages or they are urban dwellers, or any other status, social status, will not prevent them from accessing quality care. So this is the concept of universal health coverage. In the next slide, we see the dimensions, the 3 dimensions of achieving universal health coverage. We all know this box, I believe, or majority of us at least aware about this box of the 3 dimensions of universal health coverage. One, that universal health coverage should cover as much population as possible. The target is to cover all population. And the second dimension is the service. The target is to cover all healthcare services. And then lastly, to reduce financial hardship or to reduce cost, of course, on the population. Of course, to reduce expenditure, direct expenditure from people. These are the major 3 dimensions of universal health coverage. But you can see the red box in the bigger white box signifies the available resources that are currently available for the provision of maybe for healthcare services. You can see we are yet to cover all the population. That is from the far left. You can see that there are a percentage of population that is not covered, where that we see how we extend the coverage to cover people that are not covered. And from the far right, you can see that there are still some other services, particularly cosmetics and other expensive services, particularly in Nigeria, that are not covered by any policy, healthcare policy in Nigeria, including the social health insurance. So we see how we can extend the services to be covered to cover all the healthcare services, including preventive and even palliative and even cosmetic healthcare services. And then lastly, to reduce cost, right, by cost sharing, meaning by pooling resources, mostly through social health insurance, or what is normally called the Bismarck model for healthcare financing. Maybe we'll talk a little about this model maybe subsequently when we come to the issue of purchasing. And this is another explanation for the box that had already been presented in the earlier slides. So I don't think it's very necessary to go through again, only that we know the dimensions. One, the population to be covered. Two, the services to be provided. And three, the cost to be minimized or reduced on the population so that they will not be exposed to any financial hardship because of the purchasing of healthcare services. So if you can cover these three effectively, then you achieve 100% universal. We can remember. Sorry, noise is really disturbing. You achieve these three dimensions in full, we say you have 100% universal health coverage. Otherwise, you are rated according to what percentage of people you cover, what percentage of services is covered in the country, and what level of cost that is being reduced on individuals. Nigeria, we looked at some statistics that were given earlier. We said our universal health coverage was only 38%. Maybe subsequently we talk about why the universal health coverage is so low in Nigeria and very high in some other countries. So the next slide will talk about the the health financing. Yeah, health financing involves three basic functions. These are the functions of health financing anywhere in the world: to generate revenue for health, to pool the resources or risk together, and then to make purchases for the services. These are the three pillars or three basic functions of any healthcare financing around the world. So our discussion for today will center around these three basic functions, so to say. By definition, when we say revenue collection, we are talking of how health systems raise money from households, businesses, government, and external sources to finance health. And for pooling deals with the accumulation and management of revenues so that members of the pool share collective health risk, thereby protecting individual pool members from large, unpredictable health expenditures. This is very important. When you pool resources, then you are protecting people or members of the pool, you are protecting them from being exposed to any health risk that may come as a result of maybe an illness that is unpredictable, or an illness that is predictable but will consume a lot of resources, sometimes even beyond the reach of the family. Sometimes a family or household will have to resort to selling their resources or assets, maybe houses or even vehicles, to finance healthcare services. So by pooling this risk and of course revenues, then you are protecting members of the pool or members of the community or the society or the citizens of the country from being exposed to such financial hardship. And lastly, purchasing refers to the mechanisms we use to purchase services from public and private providers. Who will provide, when to provide, where to provide, what is the maybe mechanisms to consider when subscribing to a particular healthcare provider. Unfortunately, in Nigeria, because of poor universal health coverage, people have no option. They just spend their resources wherever they feel affordable. Unfortunately, if there is effective pool, if there is effective healthcare pool or revenue pool for healthcare, definitely people will have to choose a very quality care before they subscribe. And of course, that will force our service providers to be very efficient, because it will have to be an issue of competition. For example, you cannot just imagine somebody to go to Canada and provide poor service. When you provide poor service, then people will no longer patronize you because they are covered. Even now here in Nigeria, people that are covered by NHIA, you realize that they are the people that are going to most expensive hospitals just because they are covered. When you go to public hospitals where you have 200 people queuing to see one medical personnel, you realize that unless for tertiary facilities, mostly for primary and secondary healthcare, you realize that whether their illness is just not that severe or they are not covered by any insurance. If they are covered by insurance, they choose the best quality around and they subscribe to it. So this is exactly what will happen if we are pooling resources. So let's talk about revenue first. Sourcing revenue for health. So what are the sources of revenue for health? We say that these sources can be public, and when you talk of public and public domestic, of course, not public external. We talk about the direct tax. That is, people will pay taxes to government, and government will use the taxes to provide healthcare, whether through their budgets, whether it is federal government, whether it is state government, or it's a local government, because we know that healthcare provision is among the concurrent list that is provided by both the federal and the state, and even local governments at the primary care level. So pooling, okay. So all these monies are coming from our taxes. Nobody is doing us any favor. Your state government is not doing you any favor because it allocates money for health in your state, whether they build hospital or they hire personnel for health, or they provide consumables or other health equipment, or whatever healthcare service they are providing. It's not out of their pocket, of course. It comes from our pocket. Some of us that are working in salaried work in formal sectors, whether public or private, we all pay personal income tax. We know that. And if you don't pay personal income tax, you pay consumption tax, such as VAT and other consumption tax. We pay excise tax. We pay indirectly import tax and all forms of taxation. Sometimes we even pay levies for health. So all these monies that government spend, they come from our tax, mostly. Sometimes you can extend tax to even involve resources that are available in the country. Like in mostly developing countries like Nigeria, where resources, particularly mineral or natural resources, are owned and controlled by the public sector, by government. So government use part of the money, like in Nigeria, part of the money of crude oil is used to provide healthcare service. So we match it with tax here because some countries will not even have mineral resources, or even if there are mineral resources, such natural resources are managed by private individuals. Government only collect royalties and other taxes with which the government provides healthcare services. So all this fall under direct tax and indirect taxes, of course. Direct taxes involve personal income tax, corporate income tax, and of course, payroll taxes. And the indirect tax may include value-added tax, sales tax, excise tax, import tax, export tax, and all forms of taxations that are indirect, where the payer is different from the person that will bear the burden. So because when a corporate company pay corporate income tax, that will be added to the price of such okay, that will be borne by the company itself. But when the company pays VAT or any other sales tax or excise taxes, the consumer or the households ultimately bear the burden of the indirect tax. And of course, other non-tax revenues, maybe from state-owned enterprises or from natural resources that we mentioned earlier. So the pool of these resources are used by government or the public sector to provide healthcare services. Then the external sources, which are divided into two, governmental and non-governmental. Governmental are those grants, both bilateral and multilateral, that is coming from another country or coming from another international organization, particularly international formal organizations or international governmental organizations, such as the United Nations, the WHO, the World Bank, and the rest. These are governmental grants that comes into the country, sometimes even in form of loan. And then the direct foreign financial transfers through non-governmental organizations. Non-governmental organizations are just the private NGOs that are present in many developing countries, of course, that bring resources with them to finance healthcare services in the country. And then there are private sources. The most prominent among the private sources is the out-of-pocket payment. Out-of-pocket payment, and then, of course, voluntary healthcare tax provision. Voluntary healthcare insurance, like private insurance, like community-based health insurance, which is CBHI, community-based health insurance, which is very much voluntarily, or somebody will have to be willing to contribute in that pool. Otherwise, it's not obliged, like the case of social insurance, which falls mostly under the public revenue. So in the next slide, we talk specific sources. We talk about the tax-based financing, that is the financing coming from government, and then the private insurance, then the social insurance, which is the Bismarck model we're talking about, like the NHIA, like the state health insurance agency, and then issue of community insurance, which is also voluntary, and then the donor agencies that non-governmental and spending. I want to talk a bit more on mostly out-of-pocket spending leading to catastrophic health expenditure, and it's not really sustainable. And we say that in Nigeria, the healthcare expenditure that is most prevalent is the out-of-pocket expenditure. Most of people pay from their pockets or from their savings when they patronize healthcare service. And this accounts for 70%. The government budget and all other sources, including NGOs, including private insurance, including social insurance, provides the remaining 30%. And of course, one major issue with out-of-pocket expenditure is normally postpaid. Postpaid, and the problem with postpaid expenditure is that you may be caught unexpected. Somebody may just fall ill, maybe towards the end of the month. If you are a worker, maybe you have already even spent your salary, and then somebody, a member of the family, falls sick, and you just have to provide for the service. And as a result of which, you realize that there will be many people in the society or community that are not covered, that cannot access healthcare service when they need it. That's why some people even resort to traditional medicine. You resort to traditional medicine, which is relatively cheaper, or sometimes even free of charge. You go to the forest and get some concoctions and give it to your patients. And of course, that leads to the high mortality rate in the country. And of course, the poor healthcare service that we provide in the country. So Nigeria is lagging behind as far as healthcare financing or universal health coverage is concerned, because solely of the prevalence of out-of-pocket expenditure, which is basically a postpaid mechanism, unlike social and private insurance and even tax-based financing that are prepaid. Of course, the tax base is also very much inefficient because of government bureaucracy. So the most effective, perhaps, may be the insurance. Insurance, where you have a dedicated agency that is saddled with the responsibility of raising revenue, pooling the resources, and purchasing the healthcare services on behalf of the members or the participants in the pool. And in such a situation, you have a wider healthcare coverage in the country. Experiences around the world have testified to that. Even in Africa, you look at Rwanda. Rwanda is very much deep, or rather, they have gone far as community-based health insurance is concerned, where they have community committees from which they raise some revenues. Those of us with experience, or those of us that read healthcare insurance in deep, will know the situation in Rwanda, and of course, situation in Kenya, of course. Kenya also has a similar community-based insurance system in which almost all members of communities are covered by the committees of the the committees at the level of community level. And of course, their governments have done very well in maybe formalizing and providing systematic process and systematic activities for such community-based health insurance, to the extent that through those community-based health insurance, majority of the population now in those countries are covered as far as healthcare service purchases are concerned. Unfortunately, in Nigeria, it is only now that the issue of community-based committees maybe is sprouting up or is coming up. I'm privileged to be a facilitator to one program, an NGO program. I think they call it Palladium Life Year program, a UK program here in Nigeria in 5 or 6 states. I'm privileged to be one of their facilitators as far as healthcare financing provision is concerned. They are leveraging on ethical financing like tithe for those of us that are Christians, or zakah for those of us that are Muslims, or waqf for Muslims, or any other form of endowment, or maybe community funds, to be maybe pooling resources together at the level of community, and then to be patronizing the state healthcare insurance agencies for their members of their respective communities. We are still in the process of developing these committees at the level of local governments in 5 or 6 northern states. 6 of the northern states, including Kano, Kaduna, Yobe, and Borno, and the other one is Jigawa. So 5 states. Some states have gone very far. I know here in Kano, about 34 local governments had been onboarded on this program, and they are doing very well. They collect money for waqf, since the population is predominantly Muslims. So waqf is just the Arabic name of endowment. And then zakah, the Arabic name for tithe that we pay in churches and other gatherings. So they use these sources of finance to raise funds in the communities. And of course, they subscribe for healthcare services in primary healthcare services around their areas. And they are doing very well. They identify the most vulnerable members of the society and provide health for them, provide health coverage for them at the state health insurance agencies. And of course, this is one of the elements of strategic financing. You prioritize whom are going to be considered first. You look at the most vulnerable, particularly women, rural women, some of them that are widows, they don't have husbands, they don't have parents, and maybe children that are orphaned, and of course, the downtrodden and vulnerable members of the society to be covered first. And then gradually you build on prioritizing who to be covered. This had been, I may be a very welcome development And of course, if all the states in Nigeria will embrace similar committees, I believe in no time you see the level of coverage will be at least to some extent, even if the service care, the service provided is not of quality, but at least you have some level of minimum care that you can access. You can go to any healthcare facility or some healthcare facilities to access services and without being exposed to any financial hardship. But when you rely on out-of-pocket expenditure, definitely you incur, the majority of population will incur catastrophic health expenditure, particularly in Nigeria, where the poverty rate is almost 67%. The poor in Nigeria are approaching 70% of the population. And of course, with the inflation in the country, and of course, the neoliberal policies of recent administrations, that most of healthcare services now, not only healthcare services, but all other government services that used to be social services before are now being deregulated, monetized, and privatized so that people will have to patronize them out of pocket. So if you continue to rely on out-of-pocket expenditure, then the situation will definitely deteriorate because of this institutional shift or the paradigm shift in the philosophy of running government in Nigeria. So this is it. I'm very much afraid that achieving universal health coverage in Nigeria will be very difficult in the situation we find ourselves. We have to re-strategize at community levels in particular. Government cannot do it. This is very obvious because government is always withdrawing its hands, particularly federal government, from provision of healthcare services. And we all know because we all operate within the system, or at least we go there for accessing care. Even if you are working in a public hospital, maybe for any member of your family that may fall sick, you will have to go and patronize private care. You will not take them to public. So this is the situation we find ourselves, and without prepared modes of financings or mechanisms, definitely Nigeria could hardly achieve universal health coverage anytime soon, or even in the longer term. So this is just by the way. Still on the sources of healthcare financing, there are sources that are very much innovative. There are sources that are very much innovative that are not traditional, maybe in the next slides. In some countries, okay, I already mentioned the role of micro contributions, particularly at the level of communities. The 500, 1,200 naira that you contribute, maybe monthly or quarterly or even annually, to pull it together to subscribe to any state health insurance service will make a difference. And some countries are leveraging on that. I made mention of Rwanda and Kenya, and I gave example with some states here in northern Nigeria, which I have a first-hand experience being their facilitator. And of course, we guide them on researches and way of maybe investment where they can even invest their resources so that they can get more profit to buy more healthcare services for their members. So micro contributions have become one of the options, particularly in less developed countries. Of course, the issue of innovative taxes, which is being used by governments. These innovative taxes can be in form of sin tax. I gave example of it down there. Sin tax is an innovative tax. You tax such commodities that are considered harmful to health, like tobacco, like alcohol, and maybe sugary beverages, of course, that are potentially risks to the health care or to the health status of individuals. So you tax them special tax, maybe on top of the normal excise duties if they are domestic companies, on top of normal excise duties, maybe you put in additional 1% or 2% tax. That one is for their sin of maybe exposing population to the health risk. So you dedicate the additional 1% or 2% to the provision of healthcare. Many states are doing that. Many countries are doing that. In Nigeria also, I still remember last year in 2023, the previous administration wanted to introduce additional taxes on beverages because they use too much sugar and they're exposing people to diabetes. And I didn't know whether the bill scaled through. I have not followed it afterwards, but I realized that there were resistance. There were resistance from the population or from some members of the population that beverages would be more expensive if you add taxes and what have you. So also part of the innovative taxes is the taxes from oil and gas companies or other mineral explorers in the country. In Nigeria, we have that. Unfortunately, it is not dedicated for health. It's mostly dedicated for education, for TED Fund, for NASEMI, for now student loan, and the rest. And of course, mobile phone tax. Of course, this one too is not dedicated for health, unfortunately, in Nigeria. And some state governments have trust funds. I know Kano State has trust funds, healthcare trust funds, where some percentage of the total revenue collected, I think 5% will go to the fund, and they use the funds to cater for the provision of healthcare services. And of course, taxes on financial transactions when you do transfer, particularly e-transfer, financial transfer, bank transfer, so to say, they deduct some taxes. In Nigeria, I know that there is a levy, and then I don't know if there is VAT on top of the levy. The new proposed law even talk about VAT after the levy of 50 naira or 100 naira, depending on the amount you transfer. And percentage of that can be dedicated, maybe 1%, 2%, 10%, 5% to healthcare service. Sometimes even dedicate 50% because health is one of the most important commodities or services to be provided in the society. And then, of course, the ethical health financing, which I already talked about. This is also another form of innovative health financing. So it's not part of the traditional because it is not prevalent everywhere in the world. If you look at the traditional sources, they are the same sources that are used to provide healthcare services almost in the entire countries of the world. The issue of tax, the issue of out-of-pocket expenditure, the issue of social insurance, private insurance, community-based insurance, and then the donations from either philanthropic or non-governmental organizations. These are traditional, but anything out of these traditional methods can be called an innovative source of healthcare financing. So these are all sources that you can leverage upon as a healthcare manager, whether particularly at public level or at community level, or if you happen to be maybe the Minister of Health or maybe a head of agency that is solely responsible for provision of healthcare services like the social insurance agencies and what have you. You can look at how you can maybe influence the government to leverage on these innovative sources to add to the traditional sources that we have for financing health. This will go a long way in providing quality care. In fact, even the World Bank and even the United Nations had mentioned that you cannot achieve sustainable development goals through the traditional sources of financing. You have to have innovative sources of financing for you to achieve the sustainable development goals. And healthcare provision is one of those sustainable development goals. So you can think of it, it will depend on your society or community. You can even start it today as your contribution to your community. You go and meet the major stakeholders in your community. Maybe your village head, maybe your ward head, maybe your local government chairman, maybe your councillor, and some wealthy individuals, some imams, some pastors, and what have you, to show them your intention as a healthcare worker, and you see the potential of this innovative financing that can help your people in catering for their needs for healthcare. And you can make a difference with that. Honestly, Many people are making difference. They are becoming popular and impacting very much on their communities. So you can start to think in that line, even as an individual, because educated that you are, particularly in the healthcare sector. You can leverage on that to that you can your community. Sorry, somebody calling my attention. All right. So, these are the innovative sources that you can leverage upon to provide revenue for healthcare, whether as government or as a community member. You can leverage on all this. Definitely, we will not wait for government to provide health for us. Government cannot do it, particularly in Nigeria. Yes, some will say government cannot do it alone, but me, I'm saying government is not even doing it at all. So everybody should be provider for his own health, actually, and you can do more to help your people by leveraging on these innovative sources of healthcare financing, so that you see how you can help your people. That's it. So still about revenue raising. Of course, in the next slide, you see that revenue raising policy should be guided by overall healthcare system objectives. What you want to achieve as a healthcare system should guide how to raise revenue, whether from the taxes or from out of pocket or what have you. If you really want to achieve universal health coverage, I repeat and mention again that out-of-pocket expenditure is not yours. You cannot use out-of-pocket expenditure to achieve universal health coverage. And of course, public revenue sources are those which are compulsory, prepaid, and pooled. Taxes are the most common form. You see, the sources of public revenue are basically through taxes and other prepaid sources like the social health insurance. And these prepaid methods are pulled together to purchase healthcare services. And there is strong evidence that excessive reliance on out-of-pocket payments limit progress to universal health coverage. In particular, financial protection cannot be achieved. Of course, moving to a more predominant reliance on public revenue sources can mitigate this. So if government can provide everything, fine, but we know government cannot provide, particularly in Nigeria. So we have to leverage on other prepaid sources, particularly the social insurance and community-based health insurance, to see how we can cater for our people, for our communities, for our families, and the rest. So this is basically about raising revenue for the healthcare service. The takeaways from this module is that raising revenue is the first pillar of healthcare financing, and it's a must. You cannot have an effective healthcare system without enough revenue that is raised for health provision. And there are basically two sources broadly for healthcare financing: the traditional sources and the innovative sources. The traditional sources are always also divided into about three. One, the direct domestic public sources, like taxes, like social insurance. Two, the external sources, like governmental and non-governmental assistance from foreign countries or foreign organizations. And three, the private expenditure, like out-of-pocket and private insurance contribution, and even contribution to social insurance. These are all private sources. And we say that there is a strong link between prevalence of out-of-pocket expenditure and absence or slow in achieving universal health coverage. If you want to achieve universal health coverage, you have to move away from out-of-pocket expenditure, because it is not sustainable, particularly in a country that is very much ridden by poverty like Nigeria. So these are some takeaways. You have to leverage on preferred modes of financing, like taxes or social insurance, for you to achieve greater percentage or rate of universal health coverage. So these are the basic takeaways from the revenue raising for health. Then we talk about pooling. Pooling, this is simple. This is simple. It's just the accumulation and management of prepaid financial resources on behalf of some or all the population. One thing that is noticeable here is you cannot have pooling when you spend postpaid. Postpaid is just like out-of-pocket expenditure where you pay after the service. You'll be given the service and then you pay. While prepaid is normally comes from taxes, because we all pay taxes before we go to hospitals. The government will pull the taxes and then patronize healthcare services. Or social insurance. We all pay the premiums from our salaries, whether at NHIA level, at the federal level in Nigeria, or the state health insurance agencies at the state levels. And of course, we all pay prepaid before we access the service. So pooling is only applicable where prepaid sources of finances are used. You cannot use pooling where the resources are postpaid. This is one more reason to say that you can never achieve universal health coverage with a prevalence of out-of-pocket expenditure, because you cannot even pool the out-of-pocket expenditure unless through social insurance. So the objectives of pooling of resources: one, financial protection. Financial protection in the sense that if you are a member of the pool, you'll be protected. Whenever you are sick, you don't have to worry whether there is money in your account or not, whether the expenditure is high or low, whether it is this or that, you don't have to worry. You just take yourself to the nearest facility or where you have subscription, and then you get the service almost at free. Where you have co-payment, maybe you pay some 10%, 15%, or 20%. Maybe if we can have another module on health insurance, maybe we talk about reason for co-payment. Why will health insurance services impose a clause for co-payment? Maybe you pay some 5%, 10%, in some cases up to 40% of the services that are provided. So, but at least, even with the co-payment, you are partially protected. Even if the co-payment is high, up to 40%, you are still protected 60%. So pooling will help you to protect you from financial hardship. So financial protection is one major objective of pooling of risk or resources. Then equity in service use. If you pool resources, all members of the community or society, or at least all participants in the pool, will get the same quality of service regardless of their financial status. Whether you are rich or you are poor, whether you are a businessman or you are vulnerable, or you are a beggar, or you are whatever, whether you attend school or not, whether you are a health worker or not, you access the same quality care if you have pooling of resources, if you pool your resources together. Because when you pool resources, then you are pooling your health risk. So you don't have to worry for any risks. You are protected by the pool. And then, of course, these are the major objectives of pooling of resources. We say pooling is a core function of health financing policy. It's a core function of health financing policy. The others are revenue raising and strategic purchasing, which we talk about. We already discussed revenue raising, how to raise revenue. Subsequently, we are going to talk about strategic purchase. So the purpose of pooling is to spread financial risk. We talk about this across population so that no individual carries the full burden of paying for healthcare. So this is self-explanatory. This is determined by both the overall level of prepaid resources and the structural arrangement or architecture of pooling. So the level of pooling will be determined by the overall level of prepaid. That is the premium that you pay in case of social insurance, for example, like NHIA, and of course, the other architecture, the percentage, for example, the percentage that government contribute to the pool, for example. Maybe at state level, if the National Primary Healthcare Agency is contributing anything to the pool for the state healthcare insurance and what have you. This will depend, the level of pool will depend on the architecture of pooling, who are supposed to pool. Mostly the workers or the taxpayers in some cases, if you are taking of government pool, or if you are taking of health insurance, social insurance pool, you're taking of the policy holders, particularly government workers that contribute to the pool, and you talk of government itself that provide from taxes to the pool, and of course, some other agencies of government, which are all categorized as public. When pooling is fragmented, what is fragmentation? Okay, we look at fragmentation subsequently, but when pooling is fragmented, that is, you have many sources from which the purchases are coming. Like in the case of out-of-pocket expenditure, where the pool will come from each family, not at community level, not at state level. Or a situation whereby you have community-based health insurance that are comprising of only 10 or 20 or 100 people, you see the pool will be very small. And of course, the healthcare services that can be purchased from such pool will be very minimal. If you have a very big illness that will maybe consume a lot of resources, hardly a group of 10 or 20 or even 50 people, particularly if they are poor, they hardly cater for the needs at the point. So the larger the pool, the better. Fragmentation is problematic. Fragmentation is where you have small pools around that each patronize healthcare service separately. It's better you have a bigger pool, at least at local government level, if not at state level. That will ensure catering for larger health expenditure so that nobody has to worry, even if the nature of his illness will require huge amount of resources. So this is only an information that the WHO, their team of healthcare financing, works with countries to design and implement health financing policies, including policies on pooling. So there are policies on how to pool resources by WHO, and they look at the peculiarity of any country to design policy on how to pool resources. The most prevalent system is that of social health insurance. I keep repeating, just like the NHIA and the state health insurance agencies. So whatever the total level of preferred funds to make progress towards, whatever the total level of preferred funds are only pulled together to make progress towards achieving universal health coverage, because with larger pools, then you can be able to provide health services to the majority, if not all members of your community. So there are some basic principles for pooling resources. The first principle is the issue of maximization of potentials to cross-subsidize from the relatively healthy to the relatively sick. Pooling resources is only effective if it can cross-subsidize. Those that are healthy will pay, those that are sick will pay, and eventually the pool will cater for the people that are sick. So meaning the healthy population will help to subsidize the relatively sick population. When you have resources that are pulled together only by the sick, then that is not pooling at all. It does not meet the principle of cross-subsidization. So there must be cross-subsidization between the healthy and the sick. And of course, there should also be redistribution from relatively rich members of the society to those that are relatively poor, meaning that there should be equity in the pool. Those that are richer should pay higher. And of course, those that are poorer or vulnerable, sometimes they even be catered by the National Health Insurance Agency at state level. The vulnerable group that the NHIA will give some funds to state healthcare agencies to provide care for the vulnerable members. Sometimes the community will raise some funds, as I made case of ethical health financing, will raise some funds to cater for the needs of the vulnerable members of their societies. Sometimes the state government will do that on behalf of the vulnerable members. Sometimes even non-governmental organizations will do that. But the rich members of the association or of the community, or of the pool will have to pay, each according to his own income. And that is why you see for state health insurance or for NHIA, we are all contributing based on our salary. A low salary earner will pay less, and maybe an advanced worker who is on a higher level will contribute larger to the pool. And that is one basic principle for pooling resources. If the resources are only pooled by the rich and the poor is exempted, not to even benefit from the pool, then it violates the principle of good pooling. And also, if only the poor that are contributing to the pool because they need to be protected, and the rich are allowed to patronize their healthcare service out of pocket, then that one too is not a good pooling. And of course, the contribution should be independent of health risk. Whether you have a very high health risk, maybe you have history of a particular disease, or maybe maybe cases of sex workers, for example, that are very much prone to the risks of HIV and what have you. So there shouldn't be any segregation or discrimination among maybe any member because of his health risk status. Whether he's exposed to higher health risks or not, the pool must carry everyone along for it to be a good pool. So let me talk a little about fragmentation and its problems. That fragmentation of pools are said to be fragmented when there are barriers to the distribution of available prepaid funds. Of course, when the pools are fragmented in such a way that the pool for the rich is different from the pool for the poor, for example, then we say the pool is fragmented. Or maybe the pool for the healthy and the pool for the sick are fragmented, then we say there is fragmentation in the pools. And the effect of that, you see there will be inequity in distribution of resources, which is one of the major objectives of universal health coverage. If the pools are fragmented, maybe the rich have their own pool, which is maybe has the highest contribution, while the poor also have their own pool with very low contribution, then you hardly achieve equity. There will not be any cross-subsidization. That's why fragmentation is not good. And of course, it limits the financial protection and equitable access due to redistribution barriers and small pools. Of course, I made mention of that. If you have fragmentation, then you limit what you can do or what you can purchase or the people that you can protect from financial hardship, because small funds or small pools cannot cater for big illnesses. And that is why you need to have a very big pool, not fragmented one. And of course, there will be inefficiencies. Why will there be inefficiencies? Because each pool will have a separate management, And when you have too much management, the cost of management will be very high. And of course, there will be too much bureaucracy. Bureaucracy will result in inefficiency and high managerial cost, and which will lead to the reduction of the cost, of the funds that is available for purchases of healthcare services. And of course, there will be higher administrative cost because of too much administration or administrative activities resulted from too much fragmented pools. And of course, the fragmentation will weaken the potential efficiency gains of the purchasing policies. When you purchase individually or in small groups, the purchasing policies will be inefficient and will not have gains. Because if you are registering few people, 10, 20, 30 people, the cost of coverage will be higher because the agency must have to be sure that it covers maybe its own cost, particularly if in the case of insurance company, it must be sure that maybe it provides for maybe allowance for how it covers its cost. So for that reason, you see that the contributions will be very high. And of course, even the hospitals that are going to be patronized, if you are patronizing for a small number of people, you pay higher. If you are patronizing for a large number of people, you pay less. So fragmentation has all these problems. So what is a good pooling? What is the good pooling? Generally, a good pooling should have a large size in terms of the number of people covered by the pool. A good pooling should have a large size of number of people. And then 2, it must be diverse of health risks within the pool. There must be diversity of health risks within the pool. There must be some people that are sick, some that are healthy, some that are moderately healthy, some are the supposedly fully healthy. We know that nobody is 100% healthy, but there are people that look healthy. So it must have a diverse risk status as far as health is concerned. If the pool is covering for people with the same health risk, then it's not a good pool. And of course, if it is maybe registering or comprising only few people, then it is not a good pool. So as words of caution, we say that policymakers need to be clear about the multiple causes of fragmentation, what brings about fragmentation in their financing system, and use this understanding to define their goals and directions for pooling reforms. You don't just sit, particularly as a policymaker, whether a state governor or commissioner for health, or even minister at country level, and you allow people to be fragmented. These local government committees that we talk about, the health community committees at local government levels, we have the intention of a proposal. When we finish maybe registering all the local governments in each state, and they are all on board, we intend to have a bigger pool for all the local governments in the state so that they have a bigger pool that can patronize more of the healthcare services and cover as many people as possible and be as efficient as possible to reduce the bottlenecks on maybe bureaucracy at local government level. And of course, the case of small pools that may not really be very efficient and will consume a lot of resources as far as management is concerned. So when you have a single management that is very efficient, then you ensure smooth running of the pool. Maybe all you need is just to have representatives from each local government, 1 or 2 people to represent each local government on a bigger board that maybe will be formulated or formed at state level. So that's it. This is all about pooling of resources. Then the last pillar, which is the purchasing for health services. When you pool, that's not the end of it. You have to make purchases. And you don't just make purchases of healthcare services just anyhow, just the way you want it. You must be very efficient in purchasing. That's why we talk of strategic purchasing, not only purchasing, but strategic purchasing. There is a very big difference between ordinary purchase and strategic purchase. Ordinary purchase, you can purchase anything, whether you are efficient or not, right? Whether you buy what is needed or not, whether you prioritize your purchase or not, you make purchase. But strategic purchase have some good elements that must be fulfilled for such a purchase to be strategic. And that also helps in promoting universal health coverage very well. Because with strategic purchasing, you will minimize the cost of healthcare provision so that you can cover for more people and more services and reduce cost on individuals and protect them from financial catastrophe. So when we say purchasing, this is just the allocation of pooled resources on behalf of the population or members of the pool to the providers of the health services. So we are now coming to an end. Now you pool the resources and you are buying the services from the providers. This provider
Hello, sir. I think you are muted. You need to unmute yourself.
Okay. Sorry, I have network fluctuation. I had network fluctuation. I think that is why. Are we communicating now?
Yes.
Yeah, thank you very much. So for strategic purchase, there are things to be considered. There are things to be considered. As a health health financier, so to say, whether at public level, maybe agency of government you are representing, or a private healthcare financing, you must have to be strategic in purchases. And these strategic purchases will have some things that must be considered in the process. So when we say strategic purchasing, we mean making decisions about how to allocate the pool funds to providers. Who are these providers? The providers can be hospitals, can be pharmaceutical companies, can be anybody, can be even private health workers like you if you are practicing in a private, maybe private facility, so to say. So how do you make decisions to allocate these pool funds to providers? Will you just wait till somebody is sick that will come to your agency and collect money to go to hospital? Do you do that? Or you make a prepayment to these health providers like hospitals or clinics? And when you intend to make the provisions for funds to these facilities on prepaid arrangement, which methods do you use? Do you use capitation? Do you use fee for service? What do you do at that point? At the primary level, what should you do? Do you go for capitation, or you still go for fee for service at primary point of care? And if somebody is referred to secondary care or even tertiary care, do you give capitation to secondary care? Do you give capitation to tertiary care? Or you opt for fee for service or any other form of financing? These factors, all of these factors must have to be considered maybe in purchasing the services from the providers. There are factors that will guarantee that, but we are coming to that. We are coming to that. So strategic purchasing means making decisions about how to allocate full funds to providers. These providers, I mentioned some of them, like hospitals. Like which services are going to be covered by the full funds? Will you cover for even people that will come for cosmetic surgery? If yes, fine. If you have enough pool to cover for everything, fine. Will you cover for even international medical expenses if somebody is going abroad for medical care? Or you only cater for services within your country of jurisdiction? You all decided on that, the services to provide, and then which provider? Which provider? Are you referring people first to primary health care, or less or referral that they go for secondary care? You have to decide on that. Then how to pay? How to pay, whether you are paying in capitation, that is prepaid, or you are paying for fee for service after somebody must have accessed the service, then he comes for refund or anything else. And then this must have to be based on priorities, objectives, and information. These three things are very important in purchase. What are your priorities? Priorities in terms of the population you are covering, and of course, priorities in terms of the services that are supposed to cover. For example, in Nigeria, if you take away malaria in the service to be covered as not your priority, I believe you will not be a strategic purchaser, actually. And of course, what are your objectives? What are the objectives, whether you are covering for only vulnerable or you are covering for all the members of the society? What do you want to achieve? And all that will determine how you purchase and from whom you purchase and the area you are going to purchase, the proximity, the geographical location, and what have you. And of course, based on information. Information can be information on the effectiveness of the service that is provided by the service provider, so that if the service is not effective, you don't patronize them. Information can be on the health status of the population that is going to be covered, or information of the most prevalent diseases in the area. So all this must be considered. Sorry, maybe I may need strategic purchasing now for a good service provision.
Really?
Thank you. All right. So you see, these strategic purchasing mechanisms operate within each country's regulatory framework. For example, if you go to NHIA, they have their regulations on the service provider they are going to patronize. And whether you patronize the provider directly or through HMOs, the health management organizations that can maybe patronize for you, and then you pay them and all that. So it depends on the jurisdiction and the regulatory framework. Sorry, we are not discussing health insurance, so we'll not go into that, particularly that my phone is, the battery is running down gradually, less than 15% now. So I'll, quickly round up so that members can read from the slides, maybe in their free time, so that they can capture some other concepts. And of course, I will leave my phone number, maybe in case of any consultations. I will be willing to oblige. Actually, school teachers, our services are always free. All right, so in strategic purchasing, government is required to play a stewardship role by providing a clear regulatory framework as highlighted, and appropriate guidance to ensure that public health priorities are linked to resource allocation and purchasing decisions. This is very much self-explanatory. So the role of government, basically, particularly in Nigeria, the Ministry of Health and all the agencies, including the National Primary Healthcare Agency, including the National Health Insurance Agency, the NHIA, and what have you, all the stakeholders to provide frameworks on strategic purchases. But there are key strategic actions that are almost global to be considered. Mostly, in the next slide, sorry, mostly you select the providers considering their range, the quality, location. When you talk of range, I think you're talking of the range of services that they provide, then the quality of the care they provide, and then their location. When you talk of range, whether they are primary health care, this will tell you the range of services that they are providing. I realize that almost all the state health insurance agencies are only patronizing the primary health care. You only go to a secondary care on referral, something like that. Then the quality of the care they provide, and then their location. If you subscribe, you are a state agency in Kano, but you subscribe to a healthcare provider in Lagos, then you are in trouble. Your population or members of your pool cannot access the service because of the geographical location difference. That is one. So you must consider this: the provider, the range of service they provide, the quality of the care they provide, and then the location. The location must have to be accessible to your members. And then, of course, you have to establish service arrangements. Service arrangements, that is, what and what are you covering for? And then, or are you purchasing for? And then, of course, you develop formularies and standard treatment guidelines, that if somebody comes with malaria, the minimum you give to that person is so amount of drugs, and so nature of drug, whether A or B, as the case may be. So you must have such a guideline as a country, that whoever is having malaria, this is the required treatment for malaria, depending on the degree of malaria and what have you. This is just by way of example. And then establishment, the payment rates. How much are you going to pay, particularly in case of capitation, where you give the maximum amount of resources to cover for each member of the pool, or generally for the members for the pool. How much rate are you going to pay for each of them? And if it is fee for service, what percentage of that are you covering? You have to specify the rates. And then, of course, you secure information on services provided. You have to get the services, you have to have the data of the services that are provided over the period, because that will guide you on the next purchase. If many people are not going to the facilities, maybe you have to change facility, or you have to change the range of services that you provide, meaning that the services you are covering, that your people do not need such services. And of course, you have to be auditing provider claims. For strategic purchase, there must be audit. There must be audit. And of course, you have to monitor performance and act on poor performance. So of course, your provider, you have to be monitoring their activities. And of course, that may be possible from the feedback of the patients. Unfortunately, in Nigeria, many of our students here of health economics, when they conduct research, mostly on service performance, or rather the satisfaction of customers, particularly for National Health Insurance Agency, they normally report negative responses, that people are not happy with the services that are provided by NHIA, or rather the facilities that NHIA subscribe to. So this has to be monitored, and of course you'll be measuring performance of the service providers with the sole target of either maintaining the providers or change another providers, because you cannot just be given money for nothing. Actually, you have to be given money for value. And then, of course, you have to protect against fraud and corruption. The issue of fraud here, other things like adverse selection, moral hazard will come in. Sometimes you register a patient with a facility. The patient will not be sick, but will still go to the facility. This is our mentality, particularly in Nigeria. Somebody is not sick, but will go to the facility and will collect medications to go and sell. That is moral hazard. So you have to maybe have avenues through which you mitigate against all fraud and even corruption of the management of such funds, for example. One reason for co-payment in insurance is to make sure that people are not exercising moral hazard, so that only people with genuine health situation or health case that will go to the provider. People will not just go there just to collect medications because they know they are going to co-pay for the insurance. Maybe the insurance company will cover only 80% and the individual patient will give the remaining 20%. So that 20% will deter them from accessing the service when it is not genuine. So you have to provide avenues through which you protect against fraud or even corruption that is very much prevalent in Nigeria, particularly in the public sector. Of course, you have to be paying providers regularly because failure to pay them will result in poor service. And sometimes they may even maybe deny you service just because maybe you owe them some amounts of money that you refuse to pay. And then, of course, you have to allocate resources equitably. All people, all sorts of illnesses will have to be covered based on the availability of resources. And of course, all people of all stages, provided they are members of the pool, will have to be given services. That is what we mean by equity. And of course, they establish and monitor user payment policies. Yes, user payment policies, you have to be monitoring them, which is provided mostly by the authorities. And then lastly, you have to develop, manage, and use information systems. How much you collect, how much you spend, that one must be provided all the times. How much capitation you pay, how much people service, what is the balance of your pool, and what have you. All this must have to be a record for transparency and accountability. So the next slide gives us examples of purchasers. Purchasers of healthcare services include the Federal Ministry of Health, State Ministry of Health. They all patronize healthcare providers. So here, social health insurance schemes, including the NHIA and the state health insurance organizations. And of course, the health management organizations, HMOs. I don't have to be detailed on the functions of all this. I think you all know them. The community-based health insurance, as I gave example, right? The National Primary Healthcare Development Agency, the State Primary Healthcare Boards, and of course, other providers. And sometimes even personal individuals, households. Households also are also purchasers. So even if you are paying out of pocket, you have to be strategic. You don't just go and pay money where the service is not adequate or the service is not provided. And you must have to have information for you to identify the best facility to attend, even if you are spending out of pocket. So there are little challenges that may be encountered in strategic purchasing, and they are categorized into broader categories. And this will be an entirely different lecture, of course, and unfortunately, I'm running out of battery. Sorry. So there are institutional constraints. Actually, this will remain a challenge. For example, for you to release funds for NHIA or any state health insurance agency to release funds to the healthcare providers, you realize that there are too much bottlenecks, sometimes corruption, and all other sorts of inequities or inefficiencies, which are based on the institutions. And you know, institutions in Nigeria are not very strong. In fact, our major problem in Nigeria is institutional weaknesses, whether it is health institutions, including government and political institutions, education institutions, the police, the military, all over. Wherever you go, you see that the way these institutions, particularly at public level, are being run is very disheartening. And of course, there is the need for adjustment in the way they are being governed. So institutional issues or problems remain a very big challenge in strategic purchasing. Of course, sometimes even the issue of corruption, bribery for maybe a particular agency, particularly at public level, to patronize a particular service provider and what have you. Sometimes even nepotism that this health provider belongs to my younger brother or my relative, so we have to patronize them at all cost. There are many examples like that. Of course, and then the technical capacity of the insurance agencies as well. Currently, we are running trainings for state health insurance agencies in about 6 states, which is financed by the Clinton Health Initiative. Actually, if you interact with even the workers of the insurance agencies, their level of technical knowledge of what health insurance is all about actually is very low, very, very low. You may have few of them that maybe attended courses on healthcare financing and healthcare insurance, but mostly they don't even know the basic concepts of health insurance. So this technical capacity of the purchasers is another challenge. And then, of course, the public financial management rules. Generally, for example, I tend to realize that there are guidelines on how to spend money for all the state health agencies. And of course, there are cases whereby the health insurance agencies will not be allowed to spend a penny. And of course, one other area is that all the monies that will be collected cannot be invested by law. The NHIA has it as a guideline to the state health insurance agencies that they cannot invest their money, even if they are going to get profit. No matter how riskless the investment is, they cannot invest it to gain some additional funds to finance health, something like that. So these financial management rules can be a bottleneck or a challenge to effective strategic purchasing. For example, there could be a hospital that is very efficient, but the rules provided that you don't patronize such hospitals that have such characteristics. And for that reason, you have to go and patronize hospitals that are less in standard as compared to the ones that you will not patronize. And then the political economy factors. Politics in Nigeria shapes the economic policies, maybe changes in government, lack of continuity, and all other bottlenecks, particularly when there is change in party, maybe all rules and regulations governing economic activities in the country will change. Of course, one administration may even come one day and dismantle the National Health Insurance Agency totally. And this could be one of the political economy factors that may happen, and it remains a challenge to specific or strategic financing. All right, so these are some of the challenges, but these are broader challenges that if you break them into pieces, there will be an entirely different lecture on its own. How do you mitigate the challenges? What are the nature of the challenges and what have you? So towards the end, we say assessing strategic financing purchasing mechanisms. How do you assess whether your purchase is strategic or the mechanisms you use are good or bad? One, you have to look at the efficiency. Efficiency is in terms of minimization of cost and maximization of benefit. Whether you are getting value for the money you spend, whether you are achieving your objectives as an organization, whether the output matches the amount of money you spend, whether the output is achieved with least possible cost or input. So this is one very much mechanism for assessing and evaluating the strategic purchase that you make. 2, you look at equity. After efficiency, you look at equity. Equity entails about coverage, whether you are covering most members of your society and whether all members of the society, regardless of their financial status and their health risk, are being covered or not. Yes, this will serve as an instrument or yardstick or mechanism to assess your purchase. Third, the issue of accountability. Is there transparency and proper audit of whatever you are doing? If there is no accountability, nobody knows how much you spend, then corruption can come in. And if corruption comes in, then the universal health coverage will not be achieved because some few people will be stealing from the pool funds and you will not even know because of lack of accountability and lack of transparency on the use of funds. So strategic purchasing must have to be accountable. You have to account for every penny you spend. Every penny you spend, you have to account for it, and it has to be very transparent. You show all evidences that such expenditure had been incurred. And then towards the end, we have impact on quality. Impact on quality. Whether the quality of the care that is provided by the providers is improving or not. If you realize that the service that are provided by the providers is always deteriorating, then you know your purchase is not strategic. Of course, that provider will not match a good provider that should be patronized. So you have to look up where you get quality of service. These are some of the criteria or mechanisms through which you assess or you evaluate the strategic purchase that you make for healthcare services. Okay, towards the end, countries that have made sustainable progress toward universal health coverage use strategic purchasing levers to, so these are what countries that are developed as far as healthcare financing is concerned are doing to make sure that their purchases are strategic. So we listen to what Canada, US, UK are doing to ensure strategic purchase. One, they allocate resources efficiently by minimizing cost and maximizing benefits. 2, they ensure autonomy and accountability. They ensure that the agencies that are saddled with the responsibility of purchase are autonomous, independent, that they are not subject to any government manipulation. And of course, they themselves on their own, they are accountable. They are accountable to the government and to the people that subscribe their patronage. Okay, I skipped create incentives for quality, access, and equity. There are many ways you can create incentives. Luckily, you had lectures on management in the morning. I want to believe that incentives are really discussed, how a manager can provide incentives to achieve a target. These incentives can be carrot or stick. For example, you can maybe inform your provider that you will withdraw your service or your patronage if the provider is not improving on the quality of service, or if the provider is not improving on the access or the issue of equity, for example. So you use all those incentives to ensure that you give quality, accessible, and equitable care, for example. And of course, lastly, the strategic purchasing requires investments in institutional and technical capacity, and also political will. The reason why I added this case is particularly with Nigeria. You look at Rwanda. Rwanda in the 90s They fought a very bitter war, civil war. I think the most deadly in the recent history of Africa, between Burundi and Rwanda, between the Tutsis and Hutus, where millions of people were killed, millions of people were displaced, and what have you. Till when this guy, Paul Kagame, becomes the president of the country. You go to Rwanda today, you wonder if it is the same Rwanda that experienced a civil war some few years back. And you compare their healthcare system, even though their population is far, far less than that of Nigeria. Yes, of course, we have to consider all other factors, but political will is also very, very important, very, very important. And of course, the institutional capacity and technical capacity, trainings like this are very, very much important and paramount. You may be surprised, somebody who is holding a strategic position as far as healthcare financing is concerned in a state or in a country will not have this basic knowledge of healthcare financing, talk less of having a deeper knowledge on how to provide innovative sources of revenue, how to make innovative pooling of resources, and how to make innovative purchases of healthcare services. Many of them, because we interact with them. And that is the even rationale behind my department here, Department of Economics, Bayero University, mounting this program on health economics generally. Health economics, under which you will be taught healthcare financing, healthcare insurance, and even legal issues. I could see some of our products in this room, and they can testify to that. Value is added. So in case somebody will go to any political position that will patronize healthcare services or will source for revenue for healthcare financing, then the knowledge will be very much important to such a person. And that's why trainings like this, I must commend the effort of this organization, that training like this is very much important and strategic. And I want to believe that you'll be doing this at levels because you cannot exhaust everything in one day, definitely. Though I know you have diverse areas to discuss with, ranging from health sciences or health medical sciences to issue of administration, to issue of finances, to issue of many other things that will provide a very good healthcare leader. But still, maybe it has to be at levels, grades, maybe from the basics to the moderate, and of course to advanced programs. And this should be fully certified, maybe by collaboration with a registered institution if you don't have one, so that you issue certificate, you certify somebody that he has attended this training and he's capable of handling healthcare institutions with the knowledge he has in the medical science and the knowledge he has in the leadership and knowledge he has in terms of financing and all other pillars of effective healthcare services. So the next slide is thanking you all. And I raise a teaser, whether are we ready to achieve universal health coverage in Nigeria by 2030. Thank you very much for listening. And it's really an honor that I'm invited to this August event to talk to these wonderful professionals of refuge. Thank you very much.
Thank you, sir. Thank you so much for the content-filled lecture.
Thank you so much.
Yeah, I have a question and a contribution. The contribution comes first. Like Sokoto State, amongst others, is one of the states that benefits from the community financing. I know their teaching hospital, Udut, gets a lot from that services. Thank you so much. Then my question.
Yes.
Yeah. As an expert, why do you believe Nigeria cannot finance the health system, right? Is it the lack of political will, institutional decay, or why do you think so? Thank you.
You have answered the question. Sorry, if I may start from the last one. Yeah. But one, we have to bear in our minds, unless for the socialist countries, there is no any country in the world where government provides 100% care, unless for the socialist countries. And even the socialist countries are gradually leaving their socialist ideology to give some room for market participation. You're talking of Cuba, countries like Cuba, North Korea, and what have you, that are purely socialist in nature. So even those countries, nowadays, you hardly get 100% public care. And of course, on the radar, they are not the highest providers of healthcare services. You realize that there are countries that base their healthcare service on private sector initiatives, and they are achieving a tremendous percentage of healthcare services. UK is one of them. UK is one of them that statistics had shown that the countries that are leveraging more on social health insurance arrangements have the highest universal health coverage. But it's be very difficult for any country, even if it is not Nigeria, to have the 100% coverage by government through the tax-based financing. That is one. Secondly, Nigeria suffers a lot of predicament, limitations or shortcomings as far as healthcare financing is concerned because of combination of factors, of which you mentioned two most important, institutional decay and lack of political will. Of course, when you talk of institutional decay, you talk about all those factors like corruption, like maybe other issues, bribery, nepotism, maybe this lack of feeling of nationalism, so to say. We don't even feel we are Nigerians. We see ourselves first as Shamsu, or a Hausa, or a Muslim, or I'm from Kano, or I'm from so family, before we see ourselves as Nigeria. And that resulted in total decay in our institutions because we are not even thinking of upholding the institution, but thinking on how we can uphold our status as individuals, as families, or as states, or as a tribe, or ethnic group, or any other factor or dimension. So this is one, and of course you mentioned the issue of absence of political will. Yes, each government will have its own nature or dimension of interest. Actually, you see, and most of political leadership are more keen to the provision of physical infrastructure that can be seen for political goals. Most of social services like education, like health, like social security are not very much of concern to government because they are not the things that you see on roads and you see gigantic structures to score a political point, particularly at state level. Yes, that's why you see a government is able to build a very big hospitals, but the employment of health personnel, health workers, will be very, very much minimal. Very, very much minimal. Where you need 40 people to man, you employ only 4, for example, because the people will see the structure, but those passing by will not see the medical doctors that are providing the services or the physiotherapists that are providing the services to the patients. So these factors culminating together, and the general view that government cannot do it alone culminate together to bring Nigeria where it is now, which is very much unfortunate.
Thank you very much, sir.
So any other thing I will have to, I had
Any other question?
The second training I had for today, and of course I had an examination in vigilation and what have you, so I'm very much exhausted, please.
Okay, so let's relieve you, sir. Thank you
Let's
so
see if
much.
anybody have any question, 1 or 2. Otherwise, I take my leave, please.
Okay. Any other question, please? Okay, I think there is none. If there is, we still have a group, or you can send a question, and the facilitator can still respond to you either privately or otherwise. So we thank Dr. Shamsu for this in-depth lecture, and hoping to see you more in future workshops. And we also thank everyone for participating. Thank you so much all. I'm wishing you the best.
Thank you. I really appreciate it. All right. So bye, everyone. Thank you.